Sir.
So I'm starting go live on YouTube.
Anup sir, should I start the recording as well?
Yes.
Yes.
Start your recording.
Recording in progress.
Everyone has to accept it.
Yes, sir.
Done. Hello everyone. Welcome to Prayagraj. A very happy Sunday evening. So we will start our inaugural session, and I invite Dr. Sachin Yadav, Secretary, Prayagraj Orthopaedic Association, to start with our inaugural function. Dr. Sachin.
Thank you, Anurag. It's a pleasure for me to invite all the eminent faculty members who have participated in 7th UPOA Arthroplasty course. This course was supposed to take place last year, but it was because of the pandemic that we got to postpone this thing. And again, with the continuing pandemic, we have to switch for this online Zoom meeting format. It would have been a lot better had this been a physical conference, but still we have to make most out of it. I would like to call upon Dr. Kapil Gulshe, sir, the organizing president of this course, to say a few words and encourage all the new budding surgeons to make most out of this online course right now. Kapil Gulshe, sir.
Thank you, Sachin. Very good evening and greetings from Prayagraj. Our chief guest of the occasion, our own Dr. Atul Srivastav, President UPOA Dr. Sanjay Dhawan, President-elect Dr. Ashish, Secretary Dr. Anup, all the executive members of UPOA, all the learned faculty members, moderators, panelists, President and Secretaries of various orthopedic clubs of UP, all the delegates, seniors and colleagues. A very hearty welcome to this 7th Arthroplasty course of UP Orthopaedic Association. This Arthroplasty course was introduced about 8 years back, and the first course was held at Ghaziabad, and I have the privilege to give the first lecture there of the Arthroplasty course. Seeing the interest of young orthopedic surgeons in arthroplasty field, this course has become very popular and has been very beneficial over the last few years. This time we have to organize it online, but I am very much sure that this course also online also will be very helpful and useful to all the participants, as we have a very learned faculty from all across the state as well as the country. Our dynamic organizing secretary, Dr. Anurag Agrawal, has worked very hard to make it a very lively and very successful program. But if there are any shortcomings, I would personally like to apologize for the same. Without wasting much of time, I again welcome you all to this 7th Arthroplasty course, and I wish you all a very happy and useful learning. Thank you.
I would like to call Dr. Piyush Mishra, sir, existing President, Prayagraj Orthopaedic Association, to say a few words regarding the conference.
Good evening. It is an honor and privilege to start off this important academic event. First and foremost, I would like to express my deepest appreciation to the UPO President, Dr. Sanjay Dhawan, UPO Secretary, Dr. Anup Agrawal, Course Chairman, Dr. Kapil Gulshe, for putting together a riveting program. I would also like to express my sincere gratitude to Organizing Secretary, Dr. Anurag Agrawal, Secretary, Prayagraj Orthopaedic Association, Dr. Sachin, for asking me to speak at this congregation of the renowned orthoplasty surgeon from across the country. The scourge of COVID-19 is alarming, unprecedented, and challenging. This online course is a testimony of UPO commitment of providing the education to its members, especially by enhancing the quality of interaction between the academics in across the country. As we navigate this pandemic for next few months, I appreciate your support and send best to health and safety to you and your loved ones. Take care. We shall overcome this calamity. Thank you so much.
I would like to call upon Dr. Anup, sir, Secretary, UP Orthopaedic Association, to say a few words and encourage all the young orthopedic surgeons to take most out of this online course. Dr. Anup, sir.
Thank you, Sachin. I must congratulate Team Prayagraj Orthopaedic Association and organizing chairman and organizing secretary for putting up a wonderful orthoplasty course. I'm sure orthoplasty is one of the very interesting thing which interests a lot of younger surgeons, and many of the younger surgeons have joined this today, and they'll take a lot of academic things from this course. I must inform you that again next month on 21st August, we'll have a course of UPOA, that is UPOA special course, that would be on arthroscopy, yet another branch of orthopedics which is upcoming, and many of the younger orthopedic surgeons are joining that. And I'm hopeful that on 12th September, the midterm symposium of UPOA will be in hybrid mode in Lucknow, where few of the delegates would join in Lucknow physically and rest would be online. I'll take this opportunity to inform you all that like every year, Indian Orthopaedic Association celebrates 4th August at Bone and Joint Day. And this year again, we are celebrating this from 1st of August to 7th August as Bone and Joint Week. And this year theme is Save Self and Save One. Save Self means that we have to think about ourselves. This COVID period has taught us that it is important to take out time for yourself also. And Save One is where we target, I call this Mission 1 Lakh Life Saviors. Well, we'll be giving online training to 1 lakh students for basic life skills. As we know, it is one of the important missing link in initial trauma care. So once again, I congratulate Prayagraj Orthopedic Surgeons and Prayagraj Orthopaedic Association and the course chairman and course organizing secretary for organizing this course. Thank you.
I would like to call Dr. Sanjay Dhawan, sir. And currently, he is President UP Orthopaedic Association. Earlier, he was the editor of our own journal, JBJD, and he has always been an academic trust for all the surgeons all across the UP and across the nation. Dr. Sanjay Dhawan, sir, please say a few words so that we feel more compelled to join this meeting, and not only join, we all stick for the next 3 hours with the system and don't move.
Thank you. Very good evening to one and all present here. I welcome you all for joining us today on this 7th UPOA Arthroplasty course organized by Prayagraj Orthopaedic Association. Dr. Kapil sir, Dr. Anurag and their team, POA, has made untiring efforts in planning and gathering the learned galaxy of speakers to make this event a grand success. I congratulate them and extend my best wishes to Team POA. My sincere thanks to our Vice President IOA, Dr. Atul Srivastava, and Chief Guest today, for sparing time to encourage us. We are honored with your presence here. My sincere thanks to our galaxy of guest speakers, panelists, moderators from all across the country and from our UP state for sparing time and enlightening us with their competitive wisdom that has always been a treat to listen to these stalwarts. I'm sure that every bit of their deliberation and discussions is going to provide us certain useful tips which shall be very useful in our day-to-day practice. I again welcome you all. So without wasting much of your time, we straightforward move on to academics. Thanks and best wishes. Over to Anurag, please.
I would like to call Dr. Atul Srivastava, sir, Vice President IOA, our chief guest. I would like to invite him on behalf of Prayagraj Orthopaedic Association and UP Orthopaedic Association. We all feel proud of him being our Vice President IOA. Dr. Atul Srivastava, sir, please say a few kind words.
Thank you, Anurag. Well, good evening, all. And it's a proud privilege for me to be here in this webinar. I congratulate the POA and the UPOA for managing a galaxy of stalwarts in the field of arthroplasty that we have today in today's webinar. Let's all benefit from their wisdom and experience and move on to academics. Thank you for the kind invite. Thank you so much.
I would like Mr. Anurag Agrawal to take on from here and organize this very much awaited conference. I would ask Mr. Anurag Agrawal to proceed from here on. And it's a request from my side that please all the speakers stick to the given time limit so that this whole event finishes within that span of 3 hours. And nobody is compelled to leave the system. And each of us get benefited from every single words of our so very stalwart surgeons across the UP and India. Anurag Agrawal.
Thank you, Dr. Sachin. So we are now starting with our scientific session. I have few things to say that only the faculties in a particular session are allowed to unmute themselves. All the other faculties and delegates will be muted and they are allowed to ask questions only through the chat boxes. So at the end of the session, those questions will be picked up by the moderator as well as the panelists and will be passed on to respective speakers. I would like to invite Dr. Siddharth Dubey, our moderator, for the first session of knee symposium. Over to you.
Thank you, Dr. Anurag. So now let us begin this academic fiesta. And the first session of this would be on knee symposium. In this, we'll be having 5 talks of 10 minutes each. So first of all, I would like to invite the panelists of this sessions, Dr. Arun Gupta from Agra and Dr. Aamir bin Sabir from Aligarh. So for the first talk of this session, I would take the privilege of inviting Dr. J. Maheshwari from New Delhi, and he'll be presenting his talk on knee replacement in future. Over to you, Dr. Maheshwari.
Thank you, UPA, for this honor. And I thought this was supposed to be the last lecture, but somehow it is the first. But it's okay. So TKR is a common operation these days. As you know, almost every city, almost every orthopedic surgeon does it. And it's a big business industry-wise. So there are all the time new things coming up. And when we look back and say, okay, what is important? Development keep coming every other day. So what are the things that are in the future going to be important? Newer technology like robot now, and it was computer navigation earlier. Newer materials, particularly the plastic, still improving. Newer designs of prostheses, one claiming better than the other. These are ever, going things in industry because they have to show their one-upmanship. But there's another aspect to knee replacement surgery, which is partial replacement. Now, this is one area very close to my heart because my background being arthroscopy. So I've come up building up all those ligaments and cartilage, which we so mercilessly remove in knee replacement. And my heart skips a beat when I do that in a case where the damage is not so much. So I have inclination to save as much as possible wherever I can. And that's why my natural inclination to not do knee replacement if I can avoid it. So first is, are there such cases? I often hear people saying that in our society, people come very late. Now, let me tell you, that's not the case. This is my own case book for TKR. I opened up and this is what I found. And with a heavy heart, I had to remove everything because I had not counseled the patient. The uniset was not there in the OT and I did a very lovely TKR, very happy, but not really happy. Similarly, another case where patellofemoral was grade 4, whereas the tibiofemoral joint was normal. So, when you have these cases on the table, you realize, what are you doing? Why are you removing all the normal tissues? And why not replace only what is damaged? Why replace whole when only a part is damaged? Very, very logical. Human tissues are very precious. Maybe there is a reason to replace the whole of it, but then as far as possible, I would like to save whatever can be saved. Now, such patients do exist. You have to just keep your eyes open. And as you keep your eyes open, you start seeing these patients. So give you a typical example, 54-year-old lady, pain in the knee, not responding to non-operative treatment, too young for TKR. 54, everyone tells her, you wait for another 5-7 years, suffer like this, and then we will do a TKR on you very happily. But she is suffering. So what about her next 5-10 years? Not a good idea to just postpone it. Post-meniscectomy, where I know this is the compartment which is involved. Rest of the knee is going to be more or less normal. Full range of movement, everything fine. And you tell this patient TKR, he knows I'm already going to lose my range of motion. So really very, very, limited disease, limited disability, but patient has pain and is a rather well-preserved knee for a TKR. Similarly, very, very defined etiology where we know the pathology is only in one compartment. And if the patient has too much pain, why replace the whole knee? So these cases exist there. It's just that either we don't look at them or we tell them, okay, you are too early and you keep suffering till you are ready for TKR. So this is a 38-year-old lady with severe patellofemoral instability for a long time. When she was 13 years, she was operated first time for a patellar instability and now has a severe osteoarthritis of patellofemoral joint. And she is unstable patella as well as arthritic painful at the age of 38 years. And you can see this patella is not looking very good. The joint space here is reasonably maintained on the affected side. And when I looked at the MRI, it is primarily a grade 4 subluxated patellofemoral joint with severe trochlear dysplasia. Now, what do you do on a 35-year-old lady who is very active and, who has pain in the knee and this problem cannot be sorted out by any conservative methods? We do see older age people, and this is quite common, I would say. I see at least 4 or 5 every month where this patient comes with the AP lateral view of the knee with severe pain and disability, and the treating surgeon says, your arthritis is very early. I think there is something wrong. In fact, one patient was told he is psycho. Till somebody did a merchant view, and this is what it showed. Grade 4 osteoarthritis limited to only patellofemoral joint. The AP lateral looked almost normal, and you could understand why this patient had so much pain. So these patients do exist in our society, but somehow we probably miss it because I know at least in the city of Delhi, possibly not more than 2 or 3 out of 10 well-established surgeons do merchant view. Not more than 3 out of 10. The present treatment options for these cases are you try conservative, you give injection, give a brace because you're not yet prepared for knee replacement. Some people do advise arthroscopic surgery, though now it has gone completely out of fashion in osteoarthritis of the knee. It has more or less no role. In my practice, post 50 years, there is no arthroscopy, never. Osteotomy does have a role in selected population, depending on what kind of background of the patient you have. And some kind of osteotomy can give relief for maybe 8-10 years. And that's a valid option in a selected community. But knee replacement ultimately becomes a final fallout option if the patient wants a good, quick relief. But then age and everything matters. So why not a logical option of a partial damaged knee? Do a partial replacement. Why do the whole replacement? So if it is only medial compartment, just replace the medial compartment. If it is patellofemoral, only replace the patellofemoral compartment. Rest of the compartment will last for 8-10 years. And why not just give the patient the chance to live with his original knee? But there are myths associated, and I'm carrying those myths myself up and down. Every time I do a case, and every time there's a case doesn't do, I'm on this side or that side. But over the years, I have realized this technology is going to grow. It is only that how good you will become with time. Now, this was UKR does not last in 70s and 80s. And it was almost said that, okay, don't do it. But those were poor designs, poor selection of case. Nobody knew what to do. And, things evolved from that. But all the recent follow-ups, and the most recent is almost 20 years in Oxford knee lasting 92%. And all these are more than 90%, even 10 years. I've not followed up the latest results, but I know today uni lasts almost as much as UKR in terms of survival. It's only a little behind the TKR for various reasons, but it is as good an operation if it is done in the rightly indicated patients in the right way. A UKR will last long if, and this is what I took my mind to understand why my UKR should last the way my TKR lasts. Number one, the disease should not progress to other compartments, which means I have to be very choosy about current state of lateral compartment and patellofemoral compartment. No point you do a uni and then it progresses to other compartment and you'll end up with a patient who has pain. The joint shouldn't wear out, and I choose a joint which should not wear out, and we know mobile bearings are better that way because they don't wear out so fast as compared to fixed bearing. And third, of course, is if your femoral and tibial components hold on to bone, there's no loosening, there is no complication like fracture. If these three things are fulfilled, in my mind, uni should last for lifetime. Why will it fail at all if these things don't happen? So every case I see, I ask myself, is it meeting these three criteria? Of course, the first criteria is the choice of the case, and second is the choice of the implant, and the third is your own technique, whether you can do it well. So right indication is a uni-compartment disease. You have to be sure it is uni-compartment, and that has to be suggested by your clinical examination, radiological examination. I would not go into the details. And occasionally I do arthroscopy when I'm a little bit doubtful, or if I have a patient who will ask me 100 questions, then I better make it sure that it was uni-compartment to start with, and I do arthroscopy for that purpose. Now, exacting technique is very important. It's a very long, tedious learning curve, and I'm sure still I'm not there 100% to my satisfaction. If you do more than 20 per year, and after not having done surgery for almost a year in COVID, when I did my first uni, I could see how shaky I am. I wasn't so shaky in TKR, but I was shaky in UTKR. So if you don't do more than X number of cases, you don't get it there. And the time you do 4-5 in a row, you realize how smooth the whole surgery becomes. And it is only good when you do reasonable number of cases. The reason why all the statistics coming from the various registries, they show poor result because Tom, Dick and Harry is doing the surgery. It's not a surgery which everybody can do. And if you pull those results, they're bound to be poorer. But if you look at the statistics from centers which are doing high numbers, the results are actually different. So I think it is number of cases that you do that makes all the difference. Now, myth number 2, UKR not indicated if there is a patellofemoral joint involvement. This was a great thought for a long time, but it has been proven wrong again and again and again. And even now, my juniors sometimes say this is a patellofemoral arthritis, and I ignore it. And there are n number of studies which show that if you do uni, and even if to grade 3 or sometimes even up to grade 4, if it is not on the lateral compartment, you can still, in a young patient, choose uni over a TKR. That should not be an excuse to switch to TKR just because there is a grade 2, grade 3 osteoarthritis of the patellofemoral joint, because they've shown the reason for revision is almost never patellofemoral joint. It is one of those other factors like loosening, like wearing out, etc. Myth number 3, why not do a TKR directly? And this is what the patient asks. Novice patient is a very novice guy. Doctor, pura hi kar dijiye. Why do partial? Of course, it has a much lesser morbidity. It is much faster recovery. And the feel of the patient is exotic. And I have some close relatives in my family whom I've done uni, and they are like normal. They do almost everything, sit down, dance, do whatever. It's like a normal knee. It is a forgotten knee, and which is not the case with TKR. And most important is it as a backup. If something goes wrong, God forbid, you can always do UKR to TKR very easily. And we know when we have to do TKR to TKR what it means. It can be revised, but no revision TKR is as good as original TKR to speak. But when you revise UKR to TKR, it's not a big deal. Really, the results are as good as a primary TKR. Now, revision of UKR continues to be a little higher than TKR in the literature. I don't deny that. Every time I read that, it disappoints me. But then I look at my own cases and my own results and how they're doing. I find somehow I don't agree with those statistics because some of those statistics are tilted, and I can read in between the lines. For example, joint registries, they pull up everybody's cases, and how can they be as good as done by a selected set of people? And that's where sometimes this information not accurate. But where it works wonders. It looks like a normal knee. It is very, very good. Patients are very happy. And it is more like a natural knee. And revision to TKR is no big deal if ever required. Isolated patellofemoral joint replacement is another, very, very kind of, I get very, I get saliva in my mouth when I see one such patient with, isolated patellofemoral joint replacement, though they're not very symptomatic more often than not. Their problem of getting up from the chair, going up and down the stairs, but otherwise they're normal. So these patients are very difficult. They don't want any surgery. And I don't want to do any surgery anyway. But if they're disabled enough, then rather than doing a TKR, isolated PFJ replacement is a very potent option also, though technically much more demanding than even a uni-compartment replacement. As you know, patellofemoral joint itself is very complex. Even in TKR, a lot of problems happen because of patellofemoral joint. So we have still not understood the biomechanics of patellofemoral joint overall, and more so also in replacement. So pain in the knee for some time in this patient, AP, early osteoarthritis was the diagnosis, very good looking AP X-ray, and he was advised physiotherapy, did not improve. MRI was done as usual, which showed some grade 2 meniscus tear, and patient was told it's not too bad, you continue physiotherapy as long as you can. And this patient was going around because he was not happy, he was getting pain every time to get out of the car, go into the car, and we did just a merchant view, and it showed that the reason for pain is grade 4 osteoarthritis in the other compartment, which is the third compartment. And is it common to have third compartment only isolated? Yes, it is fairly common. If you start doing merchant view in your cases, even in TKR cases that I do, quite a few of them as primarily patellofemoral and secondarily tibiofemoral. And there are some where tibiofemoral is actually totally normal. So in the literature, 9.2% knees over the age of 40% have isolated patellofemoral or primarily patellofemoral disease. And it is, of course, more common in women, like all patellofemoral problems are. As far as treatment of this concern, non-operative can be tried, everything you can try, whatever. Most patients are quite happy living with this problem. I can honestly say they don't want any surgery. But there are some who are troubled. And then you start doing things like arthroscopy because minimally invasive. But let me tell you, I've tried all those things, nothing works. And lateral fasciectomy, I've tried that. It doesn't really work. But then, till the time we didn't have good or better options, patelectomy has gone out of my list. I don't know why. I think patelectomy should be a good operation for some of these rural patients, but somehow looking at the literature and looking at overall dissatisfaction rate, I have not done it and I don't do it. And then obviously fallback option is isolated patellofemoral replacement. And as per the literature, there's 80% survival in 10 years. And there's a systematic review published on this. So it is not a bad thing to do if you want to buy time, don't want to really do a TKR on somebody who has isolated patellofemoral joint disease only. Now, does it progress to other components, other parts? Well, if it is a primary osteoarthritis, it can always progress. And as you can see, good result only in 43. But if the primarily instability and trochlear dysplasia, then results are very good. And let me tell you, most young patients with osteoarthritis or patellofemoral joint have a background of this dysplasia. If the background was dysplasia, it indirectly tells you that is the cause of patellofemoral osteoarthritis, and this patient will not progress to full-blown OA of the knee. These are the better patients if you ever want to do. So best indication for PFJ replacement is a case of isolated PFJ OA with patellar malalignment, but a normal limb alignment. If the limb alignment is normal, he's not going to progress to tibiofemoral arthritis. It will limit itself to only patellofemoral joint, and if you replace that one, probably the thing will last for 10 years plus. And of course, complication-wise, both surgeries are simple when you do often enough, and we surgeons are great and we do all things very well. And I think TK, PFJs, technically PFJ I would say more demanding, but no major complication that way. This is one typical case where this lady was young, and though she had a little bit osteoarthritis of the tibiofemoral also, but at 36, I had no heart to give a knee replacement to her. And similarly, this patient was persistently subluxated patella and painful at 40 years of age. What do? You have to do replacement as well as realignment. This is a very important aspect of patellofemoral surgery because most of them have dysplasia, some kind of dysplasia. Now, this dysplasia you can correct. You can create a trochleoplasty in a way by artificial joint, but you have to correct Q angle, you have to correct all kind of. In one patient, I did even MPFL reconstruction along with this. So it's not just a replacement, it is correcting the biomechanics of the patellofemoral joint overall, and then only it works. And this is another old man with isolated patellofemoral arthritis. So I think what message I would like to give is that isolated PFJ arthritis is not that uncommon, but it is very under-recognized. And the only reason is not a good merchant view. When I ask for a merchant view in a city of Delhi, 9 out of 10 centers do give me a skyline view, which is in 80-90 degree of flexion. Very, very sad, but I have to do it again all the time. Isolated PFC replacement has evolved, and TKR is definitely overkill. My heart sinks when I remove all the normal, ACL, PCL and everything, and, feel very great about it. It doesn't give me a good feeling. So to conclude, it's just one question. You have to think about it, keep it in your mind, whether it is a uni-compartment disease, is it a limited replacement that can work? And if you are good enough and you do enough, I think that's where you move. If you're not good enough, don't do enough, maybe give that option to the patient and let somebody else who can do it. But don't do a TKR on somebody who is a limited disease, particularly active person, young person. The results of uni are so good. And there's no fall. If a fallback option is TKR, which is very good also. So I think my message would be, if you just keep it in your mind, you'll start seeing these patients more and more. And some of them may be offered a limited replacement or partial replacement. Thank you very much for your attention.
Thank you, sir. Thank you very much for your very enlightening talk and words of wisdom that one should try and conserve as much as we can, and only the part which is affected, that should be replaced. And with these words of wisdom, we very aptly move to our second talk of this session. That would be on my experience with fixed bearing uni knee by Dr. P.V. Kale from New Delhi. Dr. Kale, over to you.
Okay. Good evening and greetings from New Delhi. Is it audible? My voice is audible?
Yes, sir. Yes, sir. You are very much audible.
Fine, great. And thanks for this opportunity of sharing my experience with the uni knee arthroplasty. Taking the things forward from where Dr. Maheshwari left. Let me first confess that I am a sworn uni surgeon. If I can do a uni, I will do a uni. Okay. So you might find some of the statistics that I'm going to share with you a little more, but that's how I am. And that's how I feel. The basic problem, the basic pathology is loss of medial joint height. That's how the things start. Okay, so as the height of the medial joint is reduced, it leads to progressive ACL and MCL dysfunction. So one way to treat it is to, of course, do a TKR. We all know that. But then, Dr. Mishra has already pointed out, it's really an overkill. 60% of the joint, which is normal, especially in patients who are, in grade 2 OA. So you'll be replacing unnecessarily, and you'll be doing away with the ligaments. So that takes away a lot of natural kinematic energy. HTO is another option, but it does nothing to do the biology of the knee arthroplasty, which is the loss of cartilage. So it just corrects the mechanical deformity, shift the weight bearing onto lateral cartilage. But the ACL and MCL remain lax and more or less dysfunctional. That is why, in most studies, HTO does not last that long. Uni, on the other hand, corrects both biology and the mechanics. The ACL tension is restored, kinematics are more or less restored, and it becomes a knee which is more or less like a normal knee. And that's the main difference between how a HTO and a uni works. Uni restores the weight bearing to more or less a normal, normal kinematics. Lately, there's been a very clear divide between the designs of the uni, mobile bearing, fixed bearing, and there's a lot of debate going on which are better, fixed bearing, mobile bearing. Remember one thing, that if you look at literature, then there is not much difference between. In fact, there are studies which probably indicate that
fixed bearing unis might do a little better than mobile bearing. There's definitely less chances of lateral compartment OA. That's one of the main reasons why mobile bearings fail, because of the tightness in the middle side. And second is the wear. So a lot of studies, you can go online and check them out. Mobile bearing really does require a lot of surgical expertise to really succeed in the short term as well as in the long term. So probably fixed bearing for the surgeons who are starting this surgery. It is a surgery which is not to be, sort of done occasionally. It should be done only if you are already doing around 50 to perhaps 50 to 100 knee replacements in a year. So that if you are doing around 20 to 30% of those as uni knees, then you get a figure of 2 to 4 unis in a month, which is what you want to sort of achieve. So really a lot of advantages, faster recovery, immediate weight bearing, especially when you compare it to an HTO. You can do a bilateral procedure, high initial success rate. Yes, if you're already, experienced enough. Fewer early complications, but only if, you choose your patients well and you are very meticulous with the surgical technique. Remember, one of the earlier complications in both fixed bearing and the mobile bearing is a tibial fracture. Now, that's a very, very, it's a serious complication, and one which is totally iatrogenic. So you have to do all your, give it your utmost care to make sure that you take care of the tibial preparation when you're doing the surgery. So better cosmosis, of course, less infection, less blood loss, and the severity of the complications overall is quite less. Near normal kinematics with new unis, better material, better design, and better instruments. So all these studies are quoted and they are already there. So my experience now runs to more than 1,000 unis. I was fortunate enough to see Alligator while I was in Germany for my IGOF fellowship. And strangely enough, it was a hip fellowship for which I had gone there, and I happened to see a few alligators. But in the initial years, I did very few because the indications of unis in those days was patient less than 90 kg, patient pointing index, that patient has to point to the medial compartment. So I ended up doing little less. But then Oxford course really exposed me to a lot of, it was an eye opener really. And I started doing a lot of these cases. And I've been able to, sort of accumulate a number of cases now. Oxford Journey and Sigma HP lately. And more than 50%, about 60% of my cases, my total knee cases are now uni. So this is one of the earliest cases. In fact, this is the first one that I have done. And she was around 45, I think 48 years at that point of time. And she is now 60 plus, okay? And this is the alligator design. And you just look at the tibial design, there is no keel, there is no lug. It is absolutely fantastic. And you look at 16 years down the line, there is not even a hint of radiolucency, no loosening, no. Was very active. So, and not only these, there were a lot of alligators I did in those days, and it was a wonderful knee. Too bad that it's no longer available. We have better designs now, but the picture was not all rosy. All the complications have been there, and since I've been doing it for a long time now, like I can say that I've been there, done that, and I've seen it all.
Recording stopped. Recording in progress.
Hello?
Hello.
Yeah, I lost this. Is it
It's audible and visible. Please go on.
Okay, sorry. So, like I was saying, it's been a long time, and I've seen all the complications, but I've yet to, revise a uni for wear. So, I dare say that unis are able to last that long, although there have been problems with some of the cases that I've done. Bearing dislocation, there was one patient in which I did in osteonecrosis, the osteochondritis, which loosened, and basically presented with bearing dislocation, but no revision due to wear. Two infections which are comparatively easier to address because you can get away with one stage revision, although we need more cases to. So tibial fracture is the one problem which has continued to plague. I still get occasionally a tibial fracture. It's a very, very disheartening complication, and really sets you back. But then you need to move on, no matter what. 5 or 6 patients of them unexplained pain. I have not revised. I think 1 or 2 might have been revised, but I have not revised myself for. So some of these complications, you can see a bearing dislocation revised to a TKR, a primary TKR there. Really, the difficulty or the complexity of revision really depends on what the pathology of failure was. So in this periprosthetic fracture, just did a screw fixation, which is not right. Okay, so you have a periprosthetic fracture in a uni, put a plate. So I learned it the hard way. I had to do a full-blown revision with a stem and all. Another patient, but this time, as you can see, the implant and the bone surface is all right. So did a fixation with the plate. This time went on to heal. This patient, osteonecrosis, presented with a bearing dislocation, but actually it was loosened femur, and you can see that step sign there behind. In those days, I was using the Mark III or the phase 3 Oxford with the single peg. So there was rotational instability. So I opened the knee for reducing the bearing. Fortunately, I had the primary knee with me. It looks very grotesque, but when you take the cuts, you are able to actually, get very nice cuts, and all those bone loss is usually, it's usually taken off when you make the chamfer cuts. So although on the middle side, I did put in a screw. Femur fracture is possible. It's not my case. It's just for, to show that it is possible, although it's comparatively rare. So this patient of mine, acute infection with septicemia, presented 1 year after surgery. And the reason was he had this psoriatic lesion which got infected, secondarily infected, was a Staph aureus infection. And we did once a single stage knee revision, which went on to heal. This is 1 year post revision. He's doing fairly well. So to sum it up, UK has a lot of advantages. Some complications are there, but really, my message to the younger surgeons, because they are the ones who are going to, really, who have the ability to take this up, get away with a very, very rewarding surgery, I would say. Not only rewarding for the patient, but rewarding for the surgeon as well. Okay. And like Dr. Maheshwari said, your heart really sinks when you have to remove all that normal looking cartilage and normal ligaments to put in that knee replacement. Total knee replacement is not a bad procedure. It's a good procedure. It's a very, very good procedure. But I think uni should be in the armamentarium of every orthopedic surgeon engaged in doing joint replacement surgeries. It should be learned and should be practiced by all who are practicing arthroplasty surgery, because as Rabindranath Tagore said, that you can't cross the sea merely by standing and staring at the water. You need to get into the water to really test it out. Thank you.
Thank you, sir. Thank you very much for your talk. And I'm very happy that you stressed that TKR is not a bad surgery, because we had very two exhaustive talks on uni knee. So now let us proceed to total knee arthroplasty. And our next talk would be by Dr. A.S. Prasad from Kanpur about algorithm to correct varus deformity in total knee arthroplasty.
Thank you. And thanks, friends of the Prayagraj Orthopaedic Fraternity, and thanks for having me here. I think the varus knee is the commonest knee we see when we are doing a total knee replacement. Why? There's an inherent varus in our normal anatomy. Our joints are loaded in varus. They are in varus of 3 to 5 degree to the HK axis or the mechanical axis. And there have been a couple of papers on that, and they show that almost 50% of the population is loaded in varus, and that varus also contributes to the osteoarthritis which we see. And this is a normal picture which happens. The joints articular surface on the tibia and femur starts reducing because of the continuous degradation of the cartilage. Ultimately, either we do a S2 or I do a UKR, as everyone said. And I'm very happy with my experience of Allegretto to now PFC Sigma, high performance. So it's a good surgery. But ultimately, if we leave it that, because the lateral compartment starts getting involvement, so what it happens? Ultimately, it leads to this. There's a cartilage destruction, the osteophyte formation on the femur and tibia both stretching the medial structures, and it leads to more and more accentuated varus-looking knee. Ultimately, the soft tissue structure from the lateral side, they also start stretching, leading to varus stretch, and that can lead to a pathological fracture of the tibia underneath. So this is the now picture. How to get back, how to restore the mechanics. That means all the medial structure which are shortened or look shortened, I'll say, they have to brought back to the normal anatomy. And I told you, the collateral ligaments are static ligaments, and they are already loaded in varus. So they are best suited for a knee where the joint line is in varus. So we have to adjust that also. What are the medial structures we are talking about? There's a Frank Natter's photograph which I have taken out. You see the anterior capsule is the deepest structure of the knee, and it is just medial to that is the superficial, the vertical MCL, and the posterior to it is the oblique part of the superficial MCL. Over this, that is after that is the bursa and the pes tendons, and backwards from the on the posteromedial aspect of the tibia, the semimembranosus muscle is coming. So all these structures are there in layer by layer, but do we have to really dissect them? I don't think, because we have to find that form a soft tissue sleeve which will have all the things, and how to go about dissecting it, how to create a sleeve, and that is the most important part without damaging the collaterals, which are the main thing. If we damage it, we have it. So be prepared for medial release of a static stabilizer, that is the MCL, identification and removal of the osteophyte, that's very important. Posterior cruciate sacrificing, because sometimes the posterior cruciate, if it is shorting in the flexion deformity maximum, usually releasing or sacrificing cruciate suddenly gives a lot of space and you can balance the knee very well. Handling bone defects, the graft, screw, cement, and augments, and may add stem at times if your defect is much. Because the medial condyle of the tibia as well as femur goes into erosion. But it's more so on the tibial side, and we get a trough there, and especially the posterior medial side gets a lot of slope and deformity. Rejection osteotomy of tibia, that's a good technique to get more release on the medial side. And moreover, we have got another technique, stems and plates we must arrange. Releasing dynamic medial stabilizer, that's semi-membranosus popliteus tendon, which is going to the lateral side, and the gastrocnemius also, which is attached to the posterior side of the tibia. If we are doing a lot of releases of dynamic medial stabilizers, then we must be prepared with a lot of level of constraints also. And epicondylar osteotomy and fixation has been advocated. I have never done it. I never needed it, in fact, but it is described and people have done it. And there are publications on that. Pie crusting of MCL has become fad. It is done with the 18G needle. I have again never done it. So I'll not talk about it. But yes, it can be done like we do the posterolateral corner of the valgus knee. Something like that can be done to the MCL. But frankly, friends, I am afraid I will not touch anything on the MCL. That's very, very sacrosanct for me. So just I'll show by practical examples, and I will start with a knee, which I just did last week. And the patient is still there. She was probably going to be discharged today. A typical varus knee, which we see, a lot of osteophyte. And what we have to see, there has to be a radiological assessment. We can plan on, after looking at the X-ray. There's a lot of osteophytes on the medial side, on the femur and tibia both. On the posterior side, there's trough side osteophyte on the posterior part of the tibia with an erosion of the tibial surface. Posterior osteophytes on the femur. Probably to dislocate or subluxate the tibia anteriorly, it will be tough. So maybe we should be prepared to use a curved osteome to chip off the posterior osteophyte so that it can come out. So these are the things we decide. The bone quality looks good. So I don't think a stem will be needed, but how much bone to be cut, that we'll again decide. So this is how it looks clinically. It's a fixed varus and a fixed flexion deformity as well. So that means it's a tight knee. So maybe we'll be cutting around 8 millimeters of bone from the tibia. Femur is fixed according to the depth of the thickness of the distal femoral implant. But the most important thing, when the joint is loose or going heavier, then we have to cut minimum bone. That we must remember. And it's always minimum is the most important thing in all the things. Then creating the sleeve, that's very important. What I do, we all do like this. We cut the anterior capsule of the knee, just medial to the ligamentum patelli, leaving a sleeve. And now we go medially after cutting the anterior horn of the medial meniscus. We take it together. It is a subperiosteal dissection encompassing the superior MCL, the anterior part of the superior MCL. So the capsule is even underneath the MCL. So we go superiorly up to the mid point of the tibia on the medial side. And this is the soft tissue sleeve which will hold the anterior capsule, and the anterior MCL. And then we will take out the meniscus, we'll cut out. I keep a 2 millimeter part of the peripheral meniscus attached because the peripheral meniscus has got attachment of the MCL, the posterior oblique fiber also, and the anterior MCL, and also the deep MCL. So we are underneath the medial meniscus. We'll just put it out, and I try to go down. You see, the attachment extends up to the 6 centimeters over the tibial surface. So I'll be dissecting only around 2 centimeters of the metaphyseal area of the tibia, and then we can visualize the osteophytes. I do remove the anterior osteophyte first. I'm not trying to do anything else, because anterior osteophyte, by removing, we can keep our jig better. So that will go stepwise. So we have to do a good release, we all know, but why haste? So this osteophyte is first removed so that my jig can be kept there well. And then once I have cut the proximal tibia, then I'll remove the medial meniscus, keeping a rim there, so that we can go subperiostally down over the proximal metaphyseal tibia there. So it will be elevating the anterior part of the superior superficial MCL, the deep part of the MCL, and also the posterior oblique fibers of the MCL from the surface of the tibia. And now, because we have gone through periosteum there, we have removed around 2 centimeters of proximal metaphysis of tibia, we can easily remove all the osteophytes there. So now these osteophytes removal becomes a better or more handy, because we are getting more place there. Now the MCL, which was tight, getting small, giving us more space to work. And then we go posteriorly and try to remove all the osteophytes, because we have just done a release, and now we have got enough space to identify and remove all the osteophytes. Most important point, once we have got the surface, the anterior third or two-third anterior part of the tibia, if we go down here, will be elevating the superior superficial MCL, the anterior part. And if we go on releasing it, it influences not the medial gap in extension. It predominantly influences the medial gap in flexion. And if we damage this part by any means, we can get a mid-flexion instability easily. The gap during flexion will suddenly increase. So one has to be very, very careful here. So the anterior part, we go down over the tibia. If we keep on going down, we'll be erasing the pes bursa, and then the pes tendons also. We'll be going posterior to the attachment of the pes tendons. And then we can, if necessary, we can cut the pes tendons, and later on we can stitch that. But the posterior part is important. If the tightness is during extension, then the posterior oblique fibers, the deep MCL and the posterior oblique fibers, there we go down with the help of a osteotoma, periosteum elevator, and there will be removing a couple of attachments of the semimembranosus muscle, the superficial attachment, and we keep on going down, we'll be removing more of the semimembranosus muscle. So the attachment, not the muscle, the attachment. So this is how we can do a release based on our requirement. Just we should know where we should go down and keep on lifting the soft tissue sleeve away from the tibia, proximal tibia. Now we have got enough space, so we can put up a Homan on the medial side of the femur. We can see all the osteophytes. Again, I will not cut the osteophytes now. It will be tough. So I will go for a distal femur cut now. And suddenly all the osteophytes are so visible. Most of them have been taken away by the distal femoral cut, the surface. And now we can remove all the osteophytes. In fact, they start falling by themselves. So this again will offload the MCL. And you see, this is good enough, but this will offload the MCL for both extension and flexion both. Even you're rotating, how much rotation of this component, femoral component we do, that also influences our gap on the medial side. Little more external rotation will increase gap on the medial side. So now time has come to remove the posterior part of the meniscus, and PCL may be sacrificed if we want. In a flexion deformity, definitely it will help to take out a PCL, and now take out again, I'll keeping a rim of the meniscus intact. So that becomes a part of our soft tissue sleeve. So that strengthens the soft tissue sleeve on the medial side, which has been strengthened. And this is again a step, clearing the posterior-medial corner of the femur, because there are small osteophytes which will be denting the origin of the MCL on the femoral epicondyle. So remove that, remove the posterior costal capsule also. So this will help in a flexion deformity, but this posterior medial corner will increase your medial joints or medial gap. And that's all. I never measure anything. If I have measure, I always measure what I have cut, the bone. If I have done all the cuts and what I planned, I have cut that bone, I'll just now go ahead to do a trial. And most of the time, the trial looks good. I never have to do anything else. In gross varus, the tight knees are never a problem. The very, very loose knees are always the problem. So remember, and inflammatory or arthritis is definitely a different ball game altogether, because there the pathology lies in the soft tissue. Here the pathology is secondary to the osteophytes. Rejection osteotomy, just a slide taken from internet, how it releases the medial MCL from bowstring over the tip of the tibia. If we remove that extra bone somehow and we lateralize the tibial plate, we can overhang on the lateral side by 1 millimeter, and we take out the extra bone, and that will give us a lot of space on the medial side. So just again a slide taken from the internet. Superficial MCL anterior fibers will influence the flexion gap. The superficial MCL, posterior oblique fibers, will influence the extension gap. Deep MCL will influence both the gaps. Posterior oblique ligament is the same. It will influence the extension gap. Semimembranous tendon is there on the posterior side, will influence. If you go on down on the posterior side of the tibia, it will influence or increase the extension gap. Pes antennas tendon, posterior medial capsule, and medial gastrocnemius head. All these dynamic stabilizers do influence the extension gap. So that's all, friends. That's the basic things of medial release. I have not talked about your pie crusting, which I have never done, and I still think we don't require that. In a very grotesque deformity, which may be hardly 1% of the cases, you may require a soft tissue or dynamic releases of muscles and pes tendons. But thankfully, in last so many years of practice, I have never had the occasion to do that. Thank you. Thanks a lot.
Thank you, Prasad, sir, for your very informative talk. So what I would take from your talk is that most of the deformities can be corrected by a proper bone cuts and removing osteophytes and reduction osteotomy, and ligament releases are very rarely, excessive ligament releases are really indicated.
No, never. I never had the. In fact, sometimes the medial size is tight because we have not properly rotated the femoral component externally. Sometimes that also becomes a issue. But I still practice this, and I have never failed all the grotesque deformity. You see, the ligaments are static part. That means they cannot be shortened, they cannot be lengthened unless until you do a jet plasty or something like that. So we are trying to restore their original length. And frankly, MCL is meant for a knee in varus. So that's why the principle of kinematic knee has come, which is being practiced by some doctors in the world. Even I do practice in a couple of cases. Just I'm experimenting. My series is very less, and I don't have any idea because clinically they are all same as per my short-term results are clear. But anyway, so anatomically the ligaments we are trying to restore their length. We are not trying to lengthen them. Their attachment to the tibia can be pushed away so that they become stretched. So that is, I think that's more pathological. If we can avoid it, why not? If we cannot avoid, we are forced to do it, then we must know the technique and where we going down, so what it is going to influence. The outcome, we must be predictable. So we must be knowing, if you're going posteriorly, we'll be influencing the extension gap. If you're going anteriorly, we'll be influencing the flexion gap. Because this mistake I have seen by some doctors who wanted to increase the medial gap and they kept on erasing from the anterior side. Even they cut the elevated the pes tendon attachment.
Thank you very much, sir. Now I would like to invite Dr. Saurabh Shukla from Lucknow for his talk on algorithm to correct valgus deformity in TKA. Also, I would like to request all the participants to post your questions in the chat box so that it can be discussed in the question and answer section. Thank you. Over to you, Dr. Saurabh.
Thank you. Thank you. Can you hear me? Can you hear me?
Yes, sir, you are audible. Yes, sir, you are very much audible.
Good evening, friends and seniors. I would be presenting the valgus knee. Now, when we are novice and when we start a journey for doing a knee replacement, we often start with a primary varus knee. And when we stumble upon such a case, just in case if we want to apply the principles of a varus knee total knee replacement into valgus, we might end up having a dislocated or unstable total knee replacement. Literatures have shown that the preoperative valgus deformity has twice the failures as compared to a varus deformity after a total knee replacement. So I would be roughly discussing the cause of it and what are the principles of surgery. So what makes a valgus knee different from a varus knee? Well, obviously, it is not just the bony anatomy, but the soft tissues surrounding that bones, which are the concern. And what are the principles which are unique to the valgus knee would be my topic of interest for this evening. Now, in a valgus knee, as compared to the varus knee, which we showed, the MCL progressively attenuates, so much so that the distal femur can basically hit upon the lateral tibial plateau, causing a contained defect on the lateral tibial plateau side with a tight compartment. Not only that, the patient would have a recurrent subluxation of the patella, causing a dysplastic patella, as well as the patella to be thinned out. And because of this continuous change happening in the femur and the tibia, there could be a bone remodeling leading to a metaphyseal remodeling of the distal femur, as well as the bowing of the tibial shaft. Now, one unique anatomy of valgus knee is the lateral femoral condyle hypoplasia. And that means that the distal lateral and the posterior lateral femur is underdeveloped. And this is a unique condition which can present to us in a severe valgus. And for anybody who is doing a valgus, we should resist cutting the distal femur up to the level of the lateral distal femur. Because if we do that in a severe valgus, we can end up with a large extension gap, and along with a large attenuated MCL can give rise to a mid-flexion instability. So therefore, to circumvent this position, we have to do a conservative bone cut and rebuild the lateral distal femur by means of either screws or cement or both, so as to restore the joint line and avoid a large extension gap for preventing the mid-flexion instability. Now, once we have seen the femoral aspect, we come into the structures which cause tightness in the valgus. Now, if we look at the knee from behind, from posterior to anterior, the structures which cause tightness are: one, the lateral head of gastrocnemius. In front of it, the structures which cause tightness are the PCL, the the popliteus tendon, the lateral collateral ligament. And in front of these structures, covering them is the posterior capsule and the posterolateral capsule. That is the posterior and the posterolateral corner. On the lateral side, it is the posterior iliotibial band which causes tightness in a valgus knee. Now, there are two conditions: whether the valgus is tight in extension or in flexion or in both. So structures which cause tightness in extension are the lateral collateral ligaments and the posterolateral capsule. The structures which are tight in flexion are the popliteus ligaments and the lateral collateral ligaments. So the lateral collateral ligament, in essence, affects both the extension gap and the flexion gap. Popliteus generally remains lax in extension and tightens up in flexion. So when we approach these patients are approached by most of us by medial parapatellar approach. Keblish actually stated that we can approach them by a lateral approach with the tibial tubercle osteotomy, but I don't have an experience with that. I approach these patients with a medial parapatellar approach. Since the MCL is already attenuated, we generally
Recording
raise
stopped. Recording in progress.
The medial sleeve is a very small medial sleeve is erased just to place a homen to protect that medial sleeve while osteotomizing the tibia. If we raise the sleeve as we do it in a varus knee, we can end up having an unstable knee because of a large extension gap as a result of it. If we draw an anatomical axis, that line passes medial to the PCL insertion. And that means that when we make a pilot hole in the distal femur, it should be placed 10 millimeters medial to the PCL insertion as against at the center of the PCL, anterior to the PCL in a varus knee. And if you see the diagram, we see that the distal femoral jig does not rest on the lateral femur because of the hypoplastic nature of the valgus femur. Many studies have shown that 3 degrees valgus is now an acceptable valgus given to those knees which have to be corrected by a total knee replacement as against 5 or 6 degree valgus provided to a varus knees. When we're doing an AP cut, there are 2 ways of dealing with it. If we are finishing the femur first, either we make the anteroposterior cut perpendicular to the wide sides line or parallel to the transepicondylar axis. Or if we are using a gap balancing method and have done the tibia first, then we can make the cut, anteroposterior cut, parallel to the tibial cut surface. The tibial cut, as with the femoral cut, is also conservative. And if people who are pursuing basically a CR knee, they need to give 4 degrees of slope into the tibial cut so as to accommodate the cruciate retaining implant. Now, there are multiple methods of doing basically a balancing of soft tissues in extension and flexion. But because of the paucity of time, I chose Ranawat's method since it is the most commonly done method and it has given good results. So there are few steps of doing a Ranawat's method properly. The first and the foremost step is that before endeavoring into a soft tissue release, we must remove all osteophytes. Then there are 3 areas to palpate. The first area is the area of posterior cruciate ligament. The second area of palpation is the posterolateral corner. And third area of palpation is ITB area, the area of iliotibial band, posterior iliotibial band. These 3 areas are generally tight. People who are doing cruciate sacrificing prosthesis, they will remove the PCL remnant. And if possible, we should avoid releasing the popliteus. Ranawat's technique actually consists of 2 methods. Number 1 is releasing the capsule from the insertion right from the starting of the posterior cruciate ligament insertion point to the posterior border of the iliotibial band. And then using a number 15 blade for doing a pie crusting, horizontal pie crusting of the iliotibial band. Now, despite being a good technique, there is a concern that this technique might injure the common peroneal nerve, which is normally present at the posterolateral corner of the knee, giving rise to the foot drop. For this reason, we have to be careful that whatever sharp objects we use for balancing the soft tissues, their depth of insertion should not be more than 5 millimeters. Because the common peroneal nerve studies have shown can be as close to 1 to 1.5 centimeters around the posterolateral corner. Once we have done the extension gap balancing, the gap becomes from trapezoidal to a rectangular gap with an equal lateral and a medial space. We then come to balance the knee in flexion. In general, most of the cases have a trapezoidal extension gap, but a normal flexion gap. However, in a severe valgus or in a patient who has had a high tibial osteotomy, we might see a tight lateral gap even in flexion. And for this, there have been two methods which have been proposed. One by Dr. Ranawat, in which he does a gap balancing. He does not release any ligaments for flexion gap space instability or flexion gap inequality. He simply places the jig parallel to the tibial cut surface, and that space is then made equal to the extension gap. So by this method, he not only makes the lateral and the medial flexion gap equal, but he also ensures that the flexion gap overall is equal to the extension gap. The second method was proposed and is being done by Whiteside, in which he first releases the lateral collateral ligament and popliteus to begin with. But for people who are doing infrequent valgus knees, it is something of a concern, because studies have shown that if we release both LCL and popliteus to begin with, they have got a high dislocation rate. So therefore, for such knees or for a knee of valgus, my humble request is to do small titrated gaps releases, starting with the posterolateral capsule and iliotibial band, and check and recheck in these conditions. Patellar maltracking, the incidence of track maltracking is about 2 to 10%. And in some cases, out of 10, I probably would do 4 or 5 cases in which retinacular release is required after securing or after coagulating the superior lateral geniculate artery. I will do a longitudinal release inside out. What is the choice of implant in these patients? For patients who have got a correctable valgus, a CR or a PS implant can be done. In patients who have got PCL involved to mild to moderate category and who are strong proponents of CR implant, a lateral and an anterior release of a cruciate of the PCL and use of a cruciate retaining implant is acceptable. But if the PCL has been completely released, then a highly congruent deep dish or one with a post, that is a PS knee, is recommended. But if the MCL is completely incompetent, then a constrained implant is important to be kept off the shelf, because it can come to use in such a patient. So my algorithm is, in a mild valgus with an MCL which is competent, I would get away with doing a balanced soft tissue release in extension, starting with the posterolateral capsule, doing pie clustering of the tibia. Since the flexion gap is not affecting much, I would get away using a CR implant. But if there's a deformity which is more than 20 degrees, is fixed with an incompetent MCL, I would keep a constrained knee at bay. I would use the Ranawat's inside-out method for balancing in extension. I would erase the PCL lateral and anterior if possible, do a gap balancing method if required be, and rarely would require to erase the LCL, popliteus. I have no experience in releasing the LCL, and I don't intend to have that experience also, because as we have seen, they can cause instability. So therefore, to summarize, the valgus knee has a unique anatomy, and therefore the distal femur should be cut at about 3 degrees before entrusting or before going over to a soft tissue balancing, it is important, very important to remove all osteophytes and check and recheck. It's important to make small titrated releases rather than making large releases, and repeat testing either by trial implants or by spacers. There are three major stabilizers of the posterolateral corners: posterolateral capsule, popliteus, and LCL. It is important and pertinent to save one or preferably two of them if possible. And to begin the soft tissue release, it's important to release the posterolateral capsule and ILT build first before endeavoring upon other releases. And last but not the least, for valgus, which are severe, we should keep a constrained knee as a backup. Thank you.
Thank you, Dr. Saurav, for your very informative talk. Now, as we are done with management of complex varus and valgus deformities in TKA, let's move on to another very important but unfortunately often overlooked topic that is joint line restoration and recognition in TKA. This would be our last topic for this session, for which I would like to invite Dr. S.S. Mohanty from Mumbai. Thank you, Dr. Mohanty. Over to you.
Good evening, dear friends. First of all, let me extend my gratitude to the President of UP Orthopaedic Association, Dr. Sanjay Dhawan, Secretary Dr. Anup Agarwal, and the organizing chairman, Dr. Kapil Kulsrestha, and organizing secretary, Dr. Anurag Agrawal, for inviting me for this course. Actually, I was invited in 2018 for the UP Arthroplasty course, but I couldn't go because of some personal reasons. Incidentally, Dr. Kapil Kulsrestha and me were together in the Johnson & Johnson Fellowship exactly 25 years back in 1996. And we enjoyed that fellowship. And on a lighter note, that all our wives were pregnant during that time. And in the evening, all of us, we used to call our home to look after their well-being. And now 25 years has passed. So, dear friends, as rightly it has been told, it is often neglected to restore the joint line, to recognize while doing a total knee replacement. Now, why the joint line? Because maintaining the joint line, it restores the ligamentum balance and so the normal knee kinematics. If you do not restore the joint line, there is a possibility of decreased range of movement and especially increased patellofemoral problems and hence a compromised clinical outcome. Now, often the joint line gets elevated rather than depressed. So most commonly, the elevated joint line can lead to patellar impingement with a decreased range of movement. And there is a possibility of mid-flexion instability, which is ill understood, that how does it happen, and it is difficult to address it, after the surgery. There may be quadriceps weakness, and I told you that commonly it happens the increased patellofemoral contact forces that leads to anterior knee pain, increased component wear, and of course extension mechanism failure. But joint line depression leads to patella alta and abnormal tracking of the patella. Patient may complain of retropatellar pain and patellar subluxation. So if you go to the literature, most of the studies, they revolve around the revision total knee replacement, that how to restore the joint line during revision surgery. But very few studies, they focus on the how to restore the joint line in a primary surgery. And how much, joint line elevation or depression, it is acceptable, that is also debatable in the literature. There is no clear-cut guidelines. Now, what is joint line? Joint line is the line through the distal aspect of femoral condyles. If you see the preoperative X-ray, this is your joint line. Lateral view, this is your joint line. If you see the postoperative X-ray, this is your joint line. And in the lateral view, this one is the joint line. So change in the joint line position is often described as the difference between the preoperative and postoperative joint line position. That is the difference in the preoperative as well as the postoperative X-ray. And the value is traditionally been positive if the joint line is raised, and it has traditionally been negative if the joint line is lowered or depressed. Now, certain design consideration. Remember, those who are cruciate retaining knee users, they always take a conservative tibial cuts because in order to preserve the PCL. And in those cases, there's a possibility of elevation of joint line. So one has to be very careful while doing cruciate retaining knees. You have to be technically perfect to restore the joint line in this knee. On the other hand, mobile bearing knee has got two articular surfaces, one between the femur and polyethylene and second between polyethylene and the tibia. Since there are two functional joint lines, they combine, so they give more forgiving clinical outcome in case of rotating platform. However, on the other side, you should have a good flexion extension, gap balance in mobile bearing knee. Otherwise, your polyethylene may pop out. Now, how to assess the joint line position? The parameters, the three bony point landmarks. One is medial epicondyle, one is lateral epicondyle, one is tip of the fibula. The medial epicondyle joint line distance is about 30 millimeter. Lateral epicondyle joint line distance, joint line is about 25 millimeters, and the fibula head joint line is about 15 millimeters. But remember, this is a fixed parameters which has been given in the literature, but this may vary according to the shape of the bone. And of course, nowadays we have digital X-rays, so there is a considerable amount of magnification or reduction in those X-rays. So these parameters may not be a fixed guideline to assess on the table. So the most important parameter which came in 2014 is adductor ratio. So this is the distance from the adductor tubercle to the joint line upon the femoral width. So this is a very constant landmark value of 0.52. That means almost 50%, almost without any variation, and it is the most accurate ratio. Since it is a ratio, it doesn't depend on the size of the bone. It doesn't depend on your X-ray magnification or reduction, etc. So it has been shown that it is possible to reconstruct a joint line within 4 millimeter in about 92% of the cases. So it has been very useful. And but palpation of the adductor tubercle also is more easier and very dependable compared to medial epicondyle because that is less reliable during surgery or on the table. Now, insult salvati ratio is an indirect measurement of restoration of joint line. As you know, commonly traditionally insult salvati index, we take the patellar tendon height upon the patellar height, and if it is normal at about 1, if it is less than 0.8 patella baja and more than 1.2 patella alta. And later on also there is a modified insult salvati index where you take the articular surface of the patella measurement and the ligamentum patelli from their articular surface to the tibial tubercle, and normal is about 1.25, and it is more than 2, it is patella alta. So this indirectly shows that whether your joint line is elevated or depressed if your preoperative X-ray is normal. So how to restore it? Now in primary total knee arthroplasty, most of the time joint line is not altered, but you tend to take in certain cases like flexion contracture, sequelae of the septic knee, or post-traumatic arthritis with bone loss. There, because of excessive femoral cut, distal femoral cut, there is a possibility of elevation of the joint line. But what you do, why do you take excessive distal femoral cut? In order to achieve a full extension or achieve a normal extension gap. But first, one should try all the possible methods of soft tissue release, the posterior capsular release, taking out the posterior osteophytes, etc., before taking the last step, that excessive distal femoral cut. But if there is a choice between excessive distal femoral cut and full extension, remember the primary aim to achieve full extension, and hence their joint line restoration takes the second place. This is, for example, this is a case. This is 32 years young male, hemophiliac, 120-degree flexion deformity. This is examination under anesthesia, hardly any correction. Now 10 to 10-degree correction is there. So we achieved did a total knee replacement. Of course, this was a 3-stage surgery. First, we released the soft tissues, then put them in a serial cast correction, then did a total knee replacement, and then the serial cast correction. So as you can see here, though we have done 3-stage surgery with this difficult surgery also, we have restored the joint line. And that is a 9-year follow-up of this patient, complete extension, and about 100 to 110 degree, 110, 120 degree of flexion. So that is restoration of the biomechanics of the knee, and there's a normal function even 9 years follow-up of this patient. Now in this difficult case, post-traumatic arthritis, 49 years young male. So here placement of the femoral component, is a challenge here. So in the same stage, either you do a 2-stage surgery, take out the implant, then do a total knee replacement or second stage. But I prefer to do 1-stage surgery. So I took out the implant, could not take out these 3 screws. But on the other hand, if I would have taken out this screw, then I would have put a stem extender there. And there's such a narrow canal with a sclerosed canal, it has been difficult to put a stem extender there. So I had to adjust the femoral component and put it in this position. So placement of the femoral component is extremely important. But in that bargain, I had to lose the joint line. I landed up in little patella baha. But in spite of that, 4 years follow-up shows patient's function is very good and achieved almost 90 degrees of movement, but the restriction of the movement mostly due to the scarring of the soft tissue structures around there and the painless mobility of this patient. Now in revision situation, when there's a bone loss in the distal femur due to osteolysis, loosening, or maybe proximal migration of the component, or because of your implant removal, there may be bone loss. So you tend to put your prosthesis placement over a good bone stock, and in that bargain, you put a larger insert and you elevate the joint line. When you elevate the joint line, then what happens? Your joint line gets elevated too much. So there you have to put the distal femur augment. How to decide about that? There the role of adductor ratio is important. So pre-operatively, you measure the width of the femur in a caliper on the normal side, normal femur, or else you measure the width of the femur on the affected side. And then take the 50% and intraoperatively measure that distance from your adductor tubercle to that joint line. So you put your cutting jig accordingly so that this is your proposed joint line. So whatever bone is there, then you can reconstruct with augments or take extra bone cut in order to put 4 mm or 8 mm augments. So that will restore the joint line position and joint line alignment and of course the biomechanics of the knee. Suppose this is a revision situation, 67-year-old female, polyarticular rheumatoid, infected tica, spacer was put. There are a lot of tibial bone loss. In that case, to restore the joint line, I had to, because there are a lot of bone loss in the tibia, so I can put a thicker insert and elevate the joint line and restore the joint line to the normal position. And this is the 7 years function of this lady. Sometimes nowadays we are putting a lot of sleeves and augments whenever there is a lot of proximal tibial bone loss. That may lead to elevation of the joint line when you put a thicker insert, and that may lead to patella baha. But if it is within 5 mm of your restoration of joint line, post-operative function usually not affected. We did a study in 120 patients taking primary total knee arthroplasty in osteoarthritic patients. We measured the joint line before and after surgery, excluding the osteophytes, of course. And post-operatively, we saw the OMAC and KSS knee society score in order to correlate with the functional outcome. We saw that in almost 86 or 87% of patients, the joint line was elevated, whereas only 13% there is no elevation. That means joint line was restored. But however, there was no depression of the joint line in any of these cases. The mean joint line elevation was about 3 mm. So we found there are 2 distinct groups. One group less than 5 mm and second group more than or equal to 5 mm. And if you compare these groups on the terms of OMAC score and knee society score, there is significantly higher score in group A. That means where the joint line elevated less than 5 mm compared to group B, where joint line elevated more than or equal to 5 mm. Hence, our conclusion was elevation of joint line more than or equal to 5 mm from the preoperative value has a negative impact on the post-operative functional outcome in primary total knee arthroplasty. Hence, dear friends, take-home message, joint line elevation is a common occurrence and has a significant negative impact on post-operative functional outcome in primary total knee arthroplasty. Elevation of joint line more than or equal to 5 mm from preoperative value results in poor outcome scores than in cases with less than 5 mm raised joint line. Hence, appropriate preoperative and intraoperative assessment of the joint line distance from various bony landmarks will be helpful to achieve optimum restoration of the joint line and hence good functional outcome and hence good restoration of the function for the patient. I thank you for a patient hearing.
Thank you very much, Dr. Mohanty. So now we have covered all the 5 talks on various aspects of knee replacement from basics to future. So let us move to the question and answer session. for which I would like to invite the panelists of this session, Dr. Arun Gupta from Agra and Dr. Aamir bin Sabir from Aligarh.
Hi. Is there any question in the chat box? I can't see any question there.
There are not much questions. There was one question by Dr. Maheshwari on unexplained knee pain. But apart from this, I cannot see much of the questions in the chat box.
To start
So,
ask the Dr. Kailey, that can we extrapolate the unicondylar knee, since we are extrapolating it in bicompartmental disease as well, that in an ACL deficient knee, can we do a UKA with the same results as compared to ACL intact knees? Dr. Maheshwari.
Yeah, so it is more or less mandatory to have a good ACL in a mobile bearing, as you would appreciate that it can slip. But if you have to do a partial knee replacement in an ACL deficient knee, if you have to, it should be more often than not fixed bearing. Though deficiency of ACL, as you will know, make the knee, micro unstable, and any micro unstable knee will increase wear rate. So ideally, no, but if we have to do partial, fixed bearing is a good option. Though nowadays they've shown that even with mobile bearing, if you have to do, reconstruct the ACL at the same time. So you combine ACL reconstruction with mobile bearing, with partial knee replacement of any kind, it takes away that negative side of ACL deficiency.
Okay. Another question, that in osteonecrosis, we have learned that
can't hear you.
Similar. Hello. Can you hear me, sir?
Yeah, now we can.
Am I audible?
Yes.
So in necrosis of femur, with same results as compared to aortic or the of medial condyle.
Your voice is breaking, Dr. Arun. Can't hear you really.
Arun, you can put your question in chat box.
Yeah, there's already one question lying in chat box for Dr. Prasad.
So Dr. Kalia, what he says is that results of partial in osteonecrosis, are they going to be any different from those of primary osteoarthritis?
Well, I've done, I think 3 patients of osteonecrosis. You need to really see the defect. If it's a large defect, then your femoral component is now placed in a very unstable situation. So probably not a good idea. But it's a small defect, and especially with the newer design, which come with the two bone pegs. Oxford phase 3 was one only. Now it has also 2 bone lugs. So some rotational stability there, but I'll be very, very wary of doing a partial knee in osteonecrosis. It all depends on the amount of bone loss that is there.
And by any instance, you will be lured to do a multi-compartmental uni knee.
So it is described, but as you know, all these operations are very technically demanding. When you have one operation, which is unicompartment replacement, very technically demanding, another operation, petrofemoral replacement, very technically demanding, you add the, two procedures, you are adding to your headache. Even if one of them doesn't work well, it will be a failure. So as of now, I have not come across a patient where I had to do, I'm looking for one, where the patient is actually very young. If the patient is something like 45, 50 and has a severe medial and a petrofemoral, after proper explanation, I may do a combined surgery. But as of now, they're all, 55, 60, and I tend to do a TKR there. I don't want to take complications of 2 sensitive operations. Both of these operations are sensitive. And coming to the osteonecrosis question, again, I say the same thing. Unicompartment is a very touch me not operation. It's a very sensitive operation already. If you have too many, caveats, okay, I want to do here also, I want to do there also, then you are pushing yourself to a situation where you will end up with a failure. So unless, osteonecrosis is very small, where I know it will come in my cuts, it will not compromise my base of the, where the process is going to sit. Otherwise, I will chicken out and say, okay, I don't want to, play with fire and rather do a TCAR.
There is a question in the chat box for Dr. Prasad that in severe varus with lateral thrust and stretched lateral structures, so how do you balance without releasing MCL?
I do release, but not to the extent the books describe. Number one, if there's a lateral thrust and the lateral ligaments are stressed, that means the gap on the lateral side will be more. So the first thing will be to take out less bone from the tibia. That will be number one. Number two, I'll still go to the trial stage and then assess how much release I want. Because preemptive release I don't like. But again, so once I go to the trial stage with keeping minimum bone cut, and then according to the need, I'll take out the trials, I'll go either on the posterior medial slope of the tibia from up to down and keep on releasing the soft tissue sleeve, or anterior side, the superficial MCL, and going behind the pes and serenus and keep on releasing till I can get a titrated, I can get a good ligament balancing.
So, Dr. Prasad, this question I asked you.
Can I add something?
Yeah.
Yeah, there is a school of thought what Dr. Prasad believes that, usually ligaments do not stretch out or, do not contract in varus knees. But I go by Dr. Ranawat's principle, and in severe varus knees, as in addition to that, taking less tibial cut, all these things, I do pie crusting of the MCL and it has worked very well. But I don't do with, 15 number blade. I do it 18 gauge needle. And 18 gauge needle, you do multiple pie crusting, and each step you stretch it out. It beautiful opens up the medial joint space, and it has worked out very well in my hands. So I do routinely, pie crusting in severe varus knees. After, of course, taking out all the osteophytes, everything, and all those structures, releasing deep MCL, etc. The last step is I do the pie crusting of MCL.
Those who are doing arthroscopic surgery to reach the posterior compartment, as Dr. Maheshwari, Dr. Shrivastava, we have to do sometimes in a tightening, a pie crusting of a posteromedial MCL to do a meniscal repair in the posterior horn. So it's now a pretty common procedure with good results.
There is a good mnemonics. Remember, atrial fibrillation, AF, pulmonary embolism, PE. Atrial fibrillation, if the, anterior fibers you release if it is tight in flexion, AF. And PE, pulmonary embolism. Posterior fibers you release if it is tight in extension. Dr. Prasad had shown those things in the slide just to, remind you during surgery, you may not remember, confuse that anterior posterior fibers. It's a good mnemonics to remember.
So regarding the question that is raised about doing a MCL pie crusting in doing meniscal repair, that's a very different game because your collateral, your cruciates are still there. So, varus valgus constraint is given by the cruciate ligaments, and your knee will not open up suddenly to any extent because those cruciates will not let it happen. Whereas, and also those knees are varus primarily. In knee replacement, we leave them in neutral. And when in neutral, you leave them and ACL, PCL is not there and hardly any constraint by the implant itself, then anything happens to MCL goes snap. So I think MCL is, I agree with Dr. Prasad, it's a very touchy structure. I almost never do pie crusting. And I will tell you my philosophy on this. There are two types of varus. One is primary varus, which is in the bones. You have femur varus, you have tibia varus. You're trying to compensate that through the joint. You will have not a rectangular gap to start with at all. You may do whatever release. Sometimes no release is required. Still, you have a trapezoidal gap. Those are the cases where you may end up doing something to the MCL. Otherwise, it's not required. Any secondary deformity is corrected automatically when you release the osteophytes or maximum a osteotomy of the medial tibia. I've almost never had to do MCL release again, except in cases where it is a primarily femur varus or a very bad tibia varus, and I want to get the alignment to my neutral alignment. There, I have to release some tissues like MCL, and what I do is I release my MCL all the way down. I don't touch pie crusting. I release my MCL all the way down. It's almost hanging in the air, and at the end, I use 2 anchors and fix it while I'm, in my flexion gap balancing. It's all loose knee. And when my knee is 90-degree flexed, I refix my MCL in new position. I don't depend on the God to refix it, and God may decide whatever it has to decide. So but I never do pie crusting because I'm scared. It may just go snap anytime, and then
Rag, I think we can move to next session because already late by 40 minutes.
Surely, sir. So this brings an end to our first session of knee. To start the next session of hip, I would like to call the moderator, Dr. Riddhivardhan from Meerut, to please go ahead.
Thank you, Anurag. Thank you so much. A very good evening to you all. And after having an excellent discussion on knee arthroplasty, we now move on to hip arthroplasty. We have been joined by 2 of our esteemed panelists. Dr. Jamal Ashraf will be joining us from Lucknow, and Dr. Rajeev Anand would be joining us from Ghaziabad. They would be chairing this session for the question and answers. And we have 5 giving us techniques on cementing in total hip arthroplasty. So let us start our first session. I would request Dr. Harish Bhende sir from Mumbai to kindly speak on total hip arthroplasty in protrusio acetabuli.
Can you hear me now?
Yes, sir, you are very much audible, sir.
Okay, great. We already are getting a little late, so without wasting a lot of time, let me begin with my lecture. Let me thank the UPOA for inviting me for this symposium. We begin this hip session with the arthroplasty in protrusio hip. Now, protrusio hip is basically medial migration of the acetabulum, and you can see that on a screen. The commonest cause is rheumatoid arthritis. Usually, other cases of inflammatory arthritis like ankylosing, etc., can also cause wear of the medial part of the acetabulum, causing the femoral head to protrude inside. And a less likely cause is a traumatic condition where you may have a acetabular fracture, usually central or a posterocentral, and you can get a protrusio in those cases also. And these are not so easy cases to do because along with the protrusion, along with the medial migration of acetabulum and femoral head, there are many other things which happens around the hip joint which has to be taken care of by a surgeon during the operation. Now, if it is an aggressive RA, you can see that there is a destruction of a head and a medial migration of the acetabulum. But many times these people are treated by steroid and many other conditions. Their bone condition is not very good. There is significant osteoporosis, and the protrusio can keep on happening till usually the trochanter hits the edge of the acetabulum. Now, these are the cases where the trochanter is actually resting quite close to the acetabulum, and that is when the protrusion stops. You get a little thickening of the medial acetabular wall, and usually because the head is so far deep inside, there is a secondary osteophyte which narrows down the acetabular opening, and the range of movement of this patient is usually significantly restricted. Many of them have only a uniaxial range of movement. They very rarely have a rotational movement or significant adduction abduction movement. They are only having a flexion extension. When we do the surgery, all these factors interfere with your operation, and we have to take care of all of them step by step. So what are the issues here? The number one issue is the amount of bone stock, especially in acetabulum. Now, we need to assess how well is or how good is a medial acetabular wall. If it is adequately thick, as you can see in this particular picture, then usually we do not have to worry too much about it. But in some of the cases, that medial wall could be very thin, very flimsy, and you have to be especially careful about removing those things and building up those walls before you can insert any acetabular component. The second question is, what implant do we use? Do we use a cemented implant or a non-cemented implant? Then the medial wall, which is deficient, we have to think about augmenting that. Should we augment with a bone graft? Should I use a mosselized bone graft, for allograft, or some kind of other structure, or bone substitute, or bone bank? So there are many options the surgeon has to think about. Then what are the intra-op care and details which you have to pay attention to? What are the post-op patient care and rehabilitation? So let us take one by one. Now, acetabular reconstruction basically means, first of all, it's a narrow opening of acetabulum. The biggest problem is dislocating this hip joint when you do the replacement surgery. What we normally like to do is open up the acetabular cavity by removing the osteophyte on the periphery. And what is important is to remove the osteophyte from the inferior part or a posterior and anterior part of the acetabulum. We do not like to remove osteophyte from the superior part, which can form the support to your acetabular component. So if the removal of peripheral osteophyte and opening up of your acetabular opening doesn't allow you easy dislocation, then obviously you have to make the neck cut first and then remove the acetabular, the femoral head component, either as a piecemeal or by a single thing using a cork screw. Now, the second thing is, once we have taken the femoral head out of the acetabulum, we need to rim the acetabulum. And again, we have to be extremely gentle in rimming. Sometimes I have just used a curette to remove the loose cartilage and the acetabular thing, and use the rimmer in a very gentle fashion. You have to also assess the depth of the acetabulum. Now, if you try to put the cup into the depth of the acetabulum to the level of protrusio, then you may have significant medialization of your center of rotation. And that doesn't go very well, because you will not get a very good function or a rotation in a hip joint. So we have to assess the depth and build up the depth by using a graft from the medial side. We have to protect the medial wall, and then we have to take a call on cemented or a non-cemented. Now, the most important part to realize here is, people usually want to use a non-cemented component, and there is nothing wrong with it. But when you want to use a non-cemented component in these cases, we have already bone grafted the medial acetabular wall. Many times the portion of a bone has also gone superiorly. So you have to assess that when you put a component of the acetabular inside the acetabular cavity, you need to have at least 40 to 50% of a direct contact between the periphery of the non-cemented component and the host bone of the patient. The commonest error which happens is, you have filled up the entire gap with a mosselized bone graft, and then you have put a non-cemented component on the top, and then there is no contact between the host bone and the periphery of a non-cemented component, and then the component can become loose. I can show you one of the case subsequently in this lecture. If you find that the amount of bone graft is too much and there is no possible exposed host bone which is there, then you may go for a cemented component, or you may even sometimes use a cage to support the bone graft and get a good base for the acetabular component to put inside. The last condition or last factor which we have to consider is the acetabular orientation, the inclination and aversion. Again, because of the change in the position of the acetabular cup, there is a central migration of the whole acetabulum. The periphery of the acetabular component may have to be aligned properly. So you have to be very careful about the inclination and aversion. The commonest error is, we have a tendency to keep the cup, the acetabular component, close to the lateral border of the acetabulum. And in the protrusio, because the acetabulum has gone inside, if you haven't built up the medial wall, you may end up putting the inferior wall or inferior edge of a cup too medially, and upper edge of a cup lined with the peripheral edge, and you end up putting a too horizontal a cup. And when that happens again, it's going to cause problem, because your hip may cause impingement when the femur flexes in the front. So you have to be careful about assessing the periphery of your original acetabulum and the periphery of your acetabular cup when you decide about the inclination and aversion of the acetabulum. Now, going on the femoral side, again, usually these are inflammatory conditions. So usually bones are osteoporotic, the medullary cavity is wide, and you may have got a soft bone. So while dislocating or relocating, it is not difficult to create a iatrogenic fracture in these cases. Many times you may not be able to use a non-cemented component as we want to use it. You may have to end up using cemented in many of these cases, because the cavity is quite wide and may not get a good fixation with a non-cemented component. Again, maintaining the offset and neck length is very, very important. And usually we try to measure this offset neck length before the surgery and try to restore that during the operation. And the last but not the least is a limb length discrepancy measurement. And during the surgical technique, we use measurement to see how much is the limb length before the dislocation is done and how much limb length is restored back after the dislocation. This issue is less difficult or less difficult to manage if you are doing surgery on a bilateral hips. Both hips are protrusive, then usually the similar thing happens on both the sides. But if it is a unilateral protrusive, then we have to be very careful about measuring the limb length before and after the implant. Now let us take some example of the X-ray. This is the X-ray of a protrusive, both the sides. On the right side, you can see that the acetabular head also is collapsed and proximally migrated. So we start with the interteardrop line, which is a baseline to make any measurement. You take a oblique 2 points at the center of the lesser trochanter, and then we take a vertical distance between the two. And you can see that this is the right side has proximally migrated along with the medial migration. Then we take the look at the tip of the trochanter. You can see the proximal migration and a centralization of a trochanteric tip. This has to be brought back out and distal during the THR surgery. Now we put an oblique line which is at 45 degrees starting from about a centimeter away from the teardrop, and this is going to be your acetabular component orientation. And if you put the acetabular component parallel to this line, then probably you are going to do it right at the end of the surgery. Usually, many times we do this planning on the table on the X-ray before the operation, but we very rarely try to make the same planning or same measurement on a post-op X-rays. So what is important is to make sure that you make the same thing on a post-op X-ray. Now here we have used a medial graft and a cemented cup, and you can see that even the stem is cemented in this case because the bone was little osteoporotic. And if you can make the same measurement, that is interteardrop line, then limb length discrepancy measurement, you can see that a restoration of the limb length is there. You can see that the trochanter is shifted laterally, and we can get a oblique orientation, the inclination of acetabulum bank on the center. So if you make these arrangement pre-op measurement and we make the post-op measurement, and if they come right, that means you have done the surgery quite well. We can also see that the trochanter has shifted not only distally but also laterally, restoring the offset and a neck length. And if you do that, then usually this patient get excellent range of movement, because usually the protrusive people before surgery has a very limited range of movement. They are extremely happy when they get a good range and they can get good abduction, because then sitting on a chair or going outdoor or traveling, climbing stair becomes much easy for them. Another case you can see that's the interteardrop line. And normally if you want to plan here, this is where you would like to have your cup. And if you want to put the cup here, then we have to put a graft on a superior part and a medial part. Other option is, in these cases, we may think of using a much larger cup. It's called a mega cup. And in which case you eliminate the need for using either a medial and or superior graft. During the surgery, you have to take a call on what we need to do. And then accordingly, you have to plan, because if you plan for a mega cup, we have to make sure that you have those adequate implant available so that you can use those things. Now, this is a bilateral protrusive case, and you can see this was a RA patient, and he had significant difficulty in walking. So we initially planned to use a medial graft, mossealized graft on this side. We did that surgery first, use the mossealized graft, and then put a cemented cup on the top. On the opposite side, we had decided to put the use of a femoral head. There, instead of mossealized graft, we put a actual segment of head. And this is another thing which you can do. Usually, when there is a protrusio, the protruded part of the acetabulum is quite similar to the segmental head of the femur. So you can just take the top of the femur and rim it from inside. So you can get a semilunar shaped graft, which is made up of host bone and which can easily remain inside, and which can form a very good strut medially so that your head doesn't go inside. The difficulty when you use a mossealized graft is when you start impacting the acetabulum inside, it is possible that the graft may leak out from the periphery and your acetabular cup may actually bottom out and remain on the bottom of the protruded acetabulum. So you have to be very careful when you use a mossealized graft that there is something which will prevent your acetabular cup from sinking inside. So whatever way you do, it doesn't really matter. If you can see the X-ray of the post-op patient of this patient, the two different techniques were used in this cases on both the sides, and that's the post-op X-ray. You can see that even the moslicized graft has healed very well, as well as the bone graft from the femoral head, which was used because it was an autograft and it is a very vascular area of a bone. And you can see there is a lateralization of your acetabular cup, so you can get a good center of rotation in a normal orientation, good lateralization of the femoral trochanteric area, so you can get good range of movement. So it is very important to think exactly how you want to build the medial wall so that you can get the near normal range of movement. Now, another case, this was a unilateral case, and this patient has a relatively better quality of bone. So we decided to use a non-cemented cup, and this was a very small lady, a small female patient, and the cup size was almost 42. And in this case, we have used a monoblock component. These are called delta motion. Unfortunately, they are not available today, but it was given by DEPU in the past. And these are monoblock ceramic on ceramic component, where for a 42 size cup, we could use 32 millimeter head. So you can get a large ball in spite of having a very small acetabular size. So this allows us to use it in a younger patient, because many of these people are quite young. They may be in 30s or 40s, and they have a very long life to go ahead. So this was a non-cemented component used because the bone quality was less osteoporotic and it was quite good. Now, this was the case I was referring to. This is not one of our case, but this is a case where a moslicized graft is used, impaction grafting is done, and a surgeon has used a non-cemented component. This case came to us for a revision in a later stage. You can see that the amount of grafting which is done surrounds all around the non-cemented cup, and hence there is not going to be any amount of bone ingrowth on the surface of this non-cemented cup, because everything is covered by an allograft or covered by a moslicized graft from the patient's bone. So these are the cases where you have to be careful of not using a non-cemented component unless you have got an adequate peripheral direct fit on the acetabular bone to the cement to your non-cemented component. This was a case where again severe medial protrusio, a lot of bone loss, and you can see that the medial wall is not intact like in the previous case. There is a defect in the medial wall, and if you want to inject or impact any moslicized bone graft here, it is quite possible they will just perforate and go into the pelvis. So obviously this is not a case where I like to impact a moslicized graft. Nonetheless, I still have to use a graft, maybe a portion of a femoral head which is there, and an additional graft taken from either allograft combination. But I have to protect it, because then I cannot use a non-cemented component. Look at the quality of acetabular bone and a bone around the pelvis. It is very osteoporotic. So here we decided to use a cage to support that bone graft. So we had to use a cage and then use a cemented component in the cage, and then the cage allows the medial graft to gradually build up and heal. So in a long run, maybe a few years down the line, if we have to go for a revision, if the cage breaks down and we have to do a revision surgery, by that time the graft would have healed very well and we can get a better medial wall. So the revision will be like almost like a primary surgery. So we have to make sure that you have to also keep components like cage, etc., to build the medial wall. This is a case where there is a medial fracture dislocation and the patient was untreated. And this patient has a significant pain, a lot of shortening, and the patient has almost a stiff hip. Now, our worry was, is the medial wall and a posterior wall intact? Is it healed? Usually, this patient, if they come within first 2-3 months, you are worried about medial integrity of a wall, and you do not know whether the wall is adequate enough. But this patient had come to us almost about 1.5 years after the injury. So the medial entire wall was healed, and in fact, the broken femoral head, you can see that, also has healed. So there was almost no movement. It was almost like a fused hip. So what we had to do is we had to cut the neck. It was not possible to dislocate. We cut the neck and actually rimmed into the head of a femur and put the graft, put the acetabular cup medially, and we could get a nice good cup here, which was a non-cemented cup. There was adequate amount of bone superiorly, posteriorly, and anteriorly, and a portion of a graft which was healed along with the remaining of the fractured bone was kept inside. It is very important to realize that in protrusio cases, the center of rotation of a hip has to be adequately lateralized. If you don't lateralize the center of rotation by keeping adequate medial bone, either by using a graft or a cage, etc., you will not get a good adequate abductor function because the center of rotation goes medial, the abductor becomes deficient, and then you may get increased risk of dislocation as well as reduced range of movement. So here we used that femoral head, which was fixed anyway, rimmed into the head and put a non-cemented cup into this patient. This was because it was almost 1.5 years following the primary injury and everything has healed into a solid mass of bone. So this was a hybrid THR. We used a cemented stem and a non-cemented cup and lateralized the acetabulum. So in nutshell, if you have an acetabulum which is protruded, we must have a specific plan in your mind. We have to decide about what we want to do to first dislocate the hip joint. Do we need to cut the femoral neck before the dislocation? How do we build up the medial wall? How do we build up the acetabulum? How do you lateralize it? Do you need a larger cup? Do you need a multi-hole cup? Do you need a cage to augment your medial wall? And then keep all the options available. So you must anticipate the problems, anticipate the implants required. You must have prepared a backup plan for your surgery. And if you do that, then your surgery will go well. I normally like to read on the previous night. Even if I have experience, it is always better to go through all those literature once in a while before the difficult case. And believe me, it makes a big difference to the surgery the very next day. Thank you very much.
Thank you so much, sir, for enlightening us on such an important topic, protrusio. The two take-home messages for me from your lecture would be to protect and build up the medial wall and lateralize the cup. And of course, I need to have a 40 to 50% of the post-bone contact if I'm using an uncemented cup. Am I right, sir?
That's absolutely right. That's very important two factors.
We are running short of time, sir. So we are moving on to our next session. Dr. Dhanasekara Raja from Coimbatore would be joining us and he would be speaking on total hip arthroplasty and dysplastic hip. Over to Dr. Raja.
Good evening, everybody. At the outset, I would like to thank the Prayagraj Orthopaedic Association President and Secretary, Dr. Sanjay Dhawan and Anup Agarwal, and the organizing secretary of this meeting, Dr. Anup Agarwal. So I'm going to talk about pre-op planning in dysplastic hip. Is my screen visible?
Yes, sir. You are visible and audible, sir.
Okay. So dysplastic hip is one of the most common causes of secondary osteoarthritis in young patients. In India, most common cause is avascular necrosis and presents with a wide spectrum of problems. So one need to understand the basic pathoanatomy and the need to do proper imaging. We need to classify the dislocations and keep adequate inventory and do a meticulous surgical technique. So failure to plan is planning to failure. I will start with the example. Patient had a left side TKR, successful TKR, but because patient had a successful TKR, he went for the same surgeon for a THR in a dysplastic hip. So no pre-op planning, acetabular side done, femoral side, he used a primary stem, acetabular trochanter is gone, subtrochanteric osteotomy not done, patient dislocated immediate post-op. He went back to the same surgeon, he tried a constrained liner, again is dislocated. And again he went back to the same surgeon, he tried to remove the implant because it got infected, could not remove. Patient presented to me with a discharging sinus, so I had to go in severe sepsis, I had to go in and remove the implants. He has to stay in the ICU for almost 1 month. So there is a lot of pathological changes in the hip happening secondary to long-standing dysplasia of the acetabulum and the high reading of the trochanter. There is pelvic tilt. Need to look at the spine and do all the planning. So if you see a patient with dysplasia, first you need to identify whether this hip is dysplastic or not. So you need to know what is the center edge angle, what is the sourcial angle. A center edge angle more than 18 degrees is diagnosed of dysplasia. And this is a horizontal acetabular index. We have a vertical acetabular index, anterior acetabular index. There is an anterior coverage. In most of the dysplastic patients, the anterior wall is deficient and the anterior coverage is less. A false profile view like this can give an adequate idea of the anterior acetabular index. And you have to look at the neck shaft angle of the femur. It can be in valgus or varus. And if you have a facility to do a CT scan and compare the transcondylar axis, we can measure how much anteversion the patient has. Most of the patients with dysplasia have higher acetabular anteversion. So the CT scan will also show what is the anterior acetabular index, anterior wall, and how much depth is available for medializing the socket and the size of the actual socket as well. So to begin with, always a good idea to have a CT scan. So Crow and Ranawat classified the dysplastic hip based on the proximal migration. So it can be type 1, type 2, type 3, and type 4. You look at the vertical height of the femoral head and see how much is displaced from the teardrop. If it displays less than 50% of the femoral head diameter, it is type 1. 50 to 75% is type 2. More than 75% is type 3. This frank dislocation is type 4. It's very important to classify the dysplasia because the treatment varies with the type of type of classification. Type 1 and type 4, the best acetabulum is available at the native acetabular level. In type 2 and type 3, the best bone is available at the pseudoacetabulum. So wherever the hip is articulating, that's where the place where you have the best bone available. So you need to classify this before you can plan the management. Once you know how much proximally it's migrated, we know how much we are going to lengthen and whether we need a subtrochanteric osteotomy or not. So for the process selection, we need to have both cemented and uncemented sockets. In the uncemented sockets, better to have small cups because these are called micro cups like 40, 42, and 44. Need to be prepared for bone graft. On the femoral side, we should have all the ornamentarium available, cemented, uncemented. In the uncemented also, we need to keep modular system like a SROM and a Wagner cone type of stem. Coming to a type 1 dysplasia, it's a 50-year-old female. You can see the dysplastic acetabulum. The head is partially migrated, less than 50% proximal migration. In the false profile view, you can see the anterior uncoverage of the head in the false profile view. So we do a planning. So in the acetabular side, we try to keep the AP capture, use a small cup. On the femoral side, because there was increased anteversion, we use a SROM type of stem. It is always we aim for a combined anteversion of 25 to 35 degrees. In a male, it is around 25 to 30. In a female, around 30 to 35. So when you have this combined anteversion, the hip doesn't dislocate. It's very important to aim for a combined anteversion of 30 to 35 because the head size is really small in this patient, and any error in acetabular side or the femoral side will lead to dislocation. So this is a post-operative X-ray. We can see we have medialized the socket and we put an uncemented socket in a slightly higher hip center. We are medialized to the floor of the socket, and we used a modular stem because of the higher anteversion. So this you can see the sleeve is facing towards the X-ray beam, and the neck is parallel to the patient plane. So we can change the anteversion with the modular stem. So we need this armamentarium. Type 2, where there is more than 50% displacement. This is an elderly patient, and we can see the head is superiorlaterally migrated. So we can place the cup slightly above the teardrop, and if there is uncoverage, up to 80% coverage is adequate. We need not bone graft if it is an elderly patient. Here I used an uncemented socket. Some amount of uncoverage has been accepted. We don't try to get a coverage from superior to inferior. We try to get a capture in the AP plane. We capture the anterior wall and posterior wall. And if any defect in the supralateral aspect, we can decide whether to reconstruct it or not. The femoral side anteversion was adequate, so we used a primary stem on the femoral side. So in a Crow type 2, we can get a slightly higher hip center and use a micro cup. High hip center with the uncemented socket has given good results. There is no problem using a high hip center, but we should not lateralize the socket. So one more example, 36-year-old female, bilateral dysplasia. We need to plan where to place the socket. The higher hip center will lead to uncoverage of the bone. But because it's a young female, I want to leave a good bone stock there. So I use the femoral head itself to reconstruct the socket. I use a lateral position, and this is a modified Harding approach. After dislocation, we can see the head is malformed. You can see the socket is flat. So this is anterior and this is posterior. We always bias our reaming towards the posterior aspect because that is where your good bone is available. Anterior wall is hypoplastic. We use a slightly higher rib center. There is uncoverage of the socket. We reconstruct with bone defect. On the femoral side, I had to change the version using a cemented stem because the patient could not afford an uncemented modular stem. I use a cemented stem. This is one option to change the anteversion using a cemented stem, and the bone graft has been used to reconstruct the socket. The right side is a type 1 dysplasia. I used an uncemented stem and uncemented socket. This is a follow-up X-ray with a good consolidation and restoration of the limb length and biomechanics of the hip. So coming to type 3, you can see is the elderly patient. Hip is migrated quite proximally. We need to look at the amount of bone available medially. So if you see there is minimal bone available medially. So this is where we can deepen the socket, introp. So this is called a medial protrusion technique. We avoid breaching the medial wall, but almost create a protrusion type of situation. And we place a small unsymmetric socket in the high hip center. We use a modular stem to restore the combined anteversion. So in a high hip center, we can use one of these 3 techniques. Either we can leave it uncovered or use bone grafts in a young patient, or we can do a medial protrusion technique. This is one more example, high hip center, where we have done a proximal hip center placement with a medial reaming, and we used a cone Wagner, which will allow diaphyseal fixation and also change in anteversion. It's a monoblock stem, and we have changed the version with using this monoblock stem with the distal fixation. So coming to Crow type 3, where the hip is subluxed and articulating in a false acetabulum, high hip center gives good results. We have to use only an unsymmetric socket. Symmetric sockets lead to high failure rate, and any defect can be reconstructed with bone defect, with a bone graft. So coming to type 4, the hip is totally dislocated. This is a young patient, 48 years. I've been walking with the limp for many years. The hip is in the gluteal region. There is no false acetabulum. Here the best bone is available at the native socket. So we need to put the cup in the native socket itself. And we use a small micro cup. We do not damage the superolateral rim. We get an AP capture, slightly medialized. Then we decide how much we need to bring the hip down. If it's very tight, then we use a SROM type of stem. We do a subtrochanteric osteotomy. We prepare the stem, put the sleeve and the trial stem, try to reduce and see how much the hip needs to come down. So we place the trial stem inside, try to reduce, and we mark the subtrochanteric osteotomy, do the osteotomy, and again reduce it, see the overlap, how much the stem and sleeve is overlapping, and we cut that remaining portion to shorten, and we can correct the anteversion also in this situation. So this has been described technique for type 4 Crow's type of dislocation. So femoral osteotomy helps in reducing the incidence of sciatic nerve palsy, because if you lengthen a hip more than 4 centimeters, chance of nerve palsy is high. And also this tension on the hip is very high and it can dislocate in the postoperative period. So shortening helps in correction of rotation and also correcting the version and the length. So this is a postoperative X-ray. Patient is allowed weight-bearing walking. And once it starts weight-bearing, it consolidates. This is the follow-up of the patient after consolidation of the subtrochanteric osteotomy. Now it is around 8 years follow-up. The limb is reduced. Always these patients have some amount of patients. They have some amount of limb. Coming to one more example of type 4 type of dislocation. This patient, elderly patient, there is no socket at all here. So I have used a cemented socket and a subtrochanteric osteotomy, and it is healed well. Patient is able to walk. So one more example, young patient, dysplastic hip. The surgeon did not medialize and used a cemented socket. This is at 5 years. It started failing, and now when he presented to the patient presented, this is the situation. So CT scan can show how much. So you can see this center image where the socket is down and the cup is dislocated supralaterally. And CT scan can show how much medial bone is available for medial reaming and placement of cup. So this is the intraoperative picture. You can see there is a flat acetabulum after removing the implants. And this is the reaming medial and medial reaming. This is the creation of the socket, placement of uncemented socket with supralateral uncoverage. This is a C-arm image. Here I used a modular stem again. Trial reduction was done. This is the final implant placement, combined anteversion restored, and supralateral defect reconstructed with bone defect. This is the post-operative picture. This is the subsequent follow-up. We've done the other side also. So the hip center has been restored and the patient is walking well. So coming to the conclusion, dysplastic hip is one of the most challenging problems the surgeon faces. You need to have a meticulous preoperative planning and good surgical technique to get excellent results. Thank you for your kind attention.
Thank you so much, sir, for sharing your experience with dysplastic hip. Take-home message for me from your presentation: the first important step is to identify the problem. Second is to classify the problem. Third is proper cup positioning in type 1 and 4 native acetabulum, and type 2 and 3 the high hip center. And of course, the role of medial protrusio technique for high hip center, which you have emphasized. And the fourth important step, combined anteversion between 25 to 35 degrees. Thank you so much, sir, for enlightening us on dysplastic hip. Moving on to our third session, Dr. Sandeep Gupta, sir, from Lucknow would be joining us and speaking on total hip arthroplasty in post-traumatic and extra-articular deformities. Over to Sandeep, sir.
Hello, good evening, everyone. I'll be talking on management of total hip replacement after trauma and deformities. So, whenever there is a trauma, either previous surgery, there is always a distorted anatomy because of surgery, because of trauma. There will be scars will be there, and we need to remove the hardware also if previously operated. It's a technically demanding surgery, and it's a longer anesthesia required. We have to tell anesthetists that epidural may be required, or a prolonged surgery may require general anesthesia. And increased blood loss, you have to arrange for blood. Proper templating will be required on the normal side. And there's a lot of inventory required, especially to remove the hardware, broken hardware, set, hollow mills, and the whole complete prosthetic inventory is also required, especially the revision instrumentation. These are the surgeries which I will not say the beginners should start with. You have to have a complete experience of revision surgery. It's like femoral revision stems will be required, and grafting will be required, especially in acetabular cases of femoral proximal femur bone loss. Auto or allograft facility should be available. And a lot of patients require mobilization of femur because there is always shortening is there. And judicious use of C-arm is required to prevent any, to avoid any malposition of component or to detect any fractures. And most of these patients are already very short. So slight shortening is always acceptable. Coming to complication, there is always increased risk of fractures, periprosthetic fractures, immediate per-op fractures and post-op fractures are there. High incidence of instability, especially dislocations are there, especially in proximal femur fractures. And we need to reconstruct the acetabulum, reconstruct the abductor mechanism, and especially some implant may be required, like dual mobility implants, especially expecting high risk for dislocations. There is increased chances of thromboembolism because of previous surgeries, prolonged immobilizations, high chance of infection. Always suspicious of infection whenever patient is previously operated. Take a frozen section, initially rule out any source of infection, like do CRP, all your blood or your infection markers should be done, and per-op frozen section should also be taken whenever you are little suspicious. And you should be prepared to put a spacer, antibiotic spacer, and you should be ready. So it is not, these are the not surgeries which a beginner should start, and you should have a complete inventory before you put your knife. So let's come to a few examples. So this is an 80 years old lady. This patient already had a proximal femur fracture on the right side, underwent DHS, and had a post-traumatic arthritis. So about 5 years back, so this side, basicervical fracture, she didn't want to have any fixation. She wanted replacement for this. And we did a bipolar. We did a dual mobility cuff to decrease the chance of dislocations, and we reconstructed the tuberosity with a cerclage wire, and a distal fixation, the mid fixation stem was used. Another case, a failed intertrochanteric fracture, previous surgeries. This you can see the multiple screws are there, and see the anatomy. It's almost coxa vara is there. A lot of shortening is there. A lot of mobilization of femur will be required. Here we used the femoral head allograft and reconstructed the proximal femur with a long stem, and a normal conventional cup, uncemented cup was used. Here you can see there is a femur, proximal femur is intact. We try to preserve the abductor sleeve with the vastus. Another case, IT fracture with a cutout. You can see the total distorted anatomy is there. The acetabulum is eroded proximally because of the lag screw cutout. So here again we use the modular tapered stem and bypass all the cortical defects A dual mobility cup was kept standby, but it was very stable, and a cerclage wire to keep the abductors in place. In the case, this is like a Crow's type 4 dislocation, which we have just heard. The patient is a 45 years old. He was neglected because of below-knee amputation, so nobody diagnosed it. There was a dislocation, and once the process measurement was taken and he was made to walk, and he could not walk, and then X-ray was done, which showed a fracture dislocation of the hip. So here again, it's like a reconstruction of the acetabulum with a femoral head with the screws, and a subtrochanteric osteotomy, a step cut osteotomy was used. A smallest size of the SROM stem was unable to negotiate, so we used a coral stem and a cerclage wire with a step cut osteotomy to keep the osteotomy a little stable. So here is a trial implant with a reconstruction of the posterior wall. There's another case, fracture pelvis, acetabular fracture, previously is operated, floating plate with resorption of a lot of bone, and there is a pelvic discontinuity. You can see the discontinuity here, and superior migration of the proximal femur. So a lot of shortening was there, about 4 centimeter shortening was there. Here, this was a very 2008 case. Here we used a cage and did a trochanteric osteotomy to get the femur down. So if this case comes to me right in the present scenario, I will do a cup cage construct with a trabecular metal and a cage inside that. So these are not biological cages, so the life of these cages is about 5 to 7 years only. So nowadays we have a cup cage constructor, so people should use that. Another case, this case is a fracture neck of femur with implant removal done. Patient has cirrhosis with pancytopenia, so all the blood components were kept ready. Here you can see in the CT scan, there is total ballooning of the acetabulum is there and total destruction of the femoral head. So a jumbo cup was used, about almost a 10 millimeter size higher than the template on the left side. So highly porous cup was used, and a conventional femoral uncemented stem was used. So these patients previous surgeries when cirrhosis and bleeds a lot, high chance of infections are there. So you have to keep all the blood components for pancytopenia and bleeding ready. In the case of malunited fracture neck of femur, you can see the lot of coxa, whereas hardly any neck is there. There is level of the trochanter, you can see it's superiorly migrated. A lot of mobilization is required in these cases. There is no neck and there is no offset. So in spite of all this modular stem, we have used a sleeve and a stem. We could restore the bit of the medial offset and the limb length. So these cases required a lot of dual fixation, like a metaphyseal fixation separately and a diaphyseal fixation separately, because there will be a diaphyseal-metaphyseal mismatch is there in these cases of malunited fractures. In the case malunited fracture, hardly any neck, coxa vara deformity, lot of shortening is there. But this case was very simple, and we just cut the neck at the base of the, just above the lesser trochanter, and restored the complete anatomy with a conventional standard hip. So templating is very important on the other side in these cases. In the case non-union proximal femur, you can see that this is a greater trochanter which is attached with the part of the femoral head. So we have to salvage this part because abductors are attached here. So what was done? Abductors was attached to the femoral stem with the cerclage wire. With these cerclage wire, there is a lot of issues, like there's metal erosion is there. Sometimes they break, they irritate the tissues and all. So nowadays, what I am doing is using a number 5 fiber wire. I'll just show one case. 75 years old, 3 months old, neglected. This is a recent case because of the COVID situation, and patient never reported to hospital. And after 3 months, they reported there's a basicervical Powell's type 3 with the intertrochanteric extension. You can see the part of the greater trochanter here. This is the X-ray, CT. So what was done? This is how the femur looks like. There's a trochanter is lying here, and we drill the 2 holes in the lesser trochanter. If lesser trochanter is not intact, you can pass these sutures into the piriformis. iliopsoas. So you can see the 2 holes here. The drill was put, and these fiber wire were passed here, and laterally the bond wire was passed, or fiber wire, whatever you can use. I use different wires so that we can identify the wires. And once you have drilled them, then you pass the final stem and the processes, and then suture it like this. One is a cerclage wire like this, and a figure wave wire from the trochanter. So you midlize the GT first, and then distalize it. So this is the final X-ray. You can see the trochanter is rightly touching into the proximal femur. In the case of malunited fracture of femur, this patient underwent multiple surgeries, fibular head graft, muscle particle graft to stabilize the union. But ultimately, patient developed avascular necrosis, and you can see the multiple lytic area. These are the suspicious area where you find the patient might be having some infection. So there was infection, and a standby spacer was kept. So we removed everything. High-speed burr was used to remove this fibula and the screws, and this spacer was put. And later on, second stage surgery was done with a standard implant and restoration of complete anatomy. So if you don't have the spacer, then at least some cement ball can be put. But always keep things ready and be suspicious of infection in these multiple surgeries patients. This is a case of excision arthroplasty. Patient underwent some trauma surgeries, neck fractures. Excision arthroplasty was done some long time back. And this is a heterotopic ossification. This is a Mayo hip. Many of the young surgeons might have not seen. The very small implant. This we used to have in our Army Hospital RNR, but now it's not available in India. So very small stem. And you can see the malunited fracture was here, which was not required to be bypassed. So this is a very interesting case. 75 years old, fracture acetabulum with a femoral head fracture. This was a femoral head fracture and the posterior wall fracture. This is a CT scan. So very rarely in the acetabular fractures, you have to do a total hip replacement. This is one of the case recently done. And this was a wall fracture, and this was a femoral head fracture. So same time, we fix the posterior wall, and then use the head graft and moisturize it, put it at the fracture site, and do an uncemented conventional THR. So this is the oblique views, iliac views, and at 3 months, fracture is all united. So it's very important, if you have these type of scenario, just don't go and just do it. If you are conventionally doing pelvic surgeries also, then you should arrange everything. And if you don't do it, then arrange a pelvic surgeon along with when you're doing a total hip replacement in these cases. So to conclude, a good preoperative planning is required, templating on the normal side, reconstruction of defect both on the femur side and the acetabular side, and restoration of center of head is very important to restore the biomechanics. So it is important, there are 3 pieces: planning, preparation, and execution of that planning. So if everything is done properly, then we can increase the longevity of these THR in difficult cases, because these patients have almost 30% chance of high complications compared to the conventional total hip replacement. Thank you very much.
Thank you, Sadeep sir, for enlightening us on such a difficult topic, total hip arthroplasty in post-traumatic and extra-articular deformities. You very rightly said these are complex situations and one must be ready with the complete inventory because you might face anything here. Move on to our next topic, management of acetabular bone defects in total hip arthroplasty. Dr. Anil Arora is joining us from Delhi. Over to you, sir.
Thank you very much. Am I audible?
Yes, sir.
So, thanks a lot, colleagues and friends. A very good evening. So, I'll be speaking on algorithm to manage acetabular bone defects in revision total hip arthroplasty. We all know acetabular bone loss remains a challenge to obtain long-lasting fixation in the face of deficiency of bone in the acetabulum. And just a small reminder, uncemented cups, once you remove, they can have more bone loss as compared to cemented cups, where it is quite obvious. There can be more hidden bone loss with uncemented cups because of these 2 factors. Now, to have an algorithmic approach for reconstruction of acetabulum in the face of bone loss, the most commonly used classification is that of Paprosky, which classified into three types, 1, 2, and 3. We'll talk about them one by one, and these are based on the following 4 parameters which are seen radiologically. So in type 1, everything is almost intact except small areas of bone loss, focal contained bone loss. And in these situations, a regular hemispherical cementless cup will give you good stability and one can go ahead and do it. No issue. This is just one example, 13-year follow-up, totally arthroplasty, right acetabula was loose. This is after removal, focal contained defects, and reconstruction with bone graft and a primary cemented cup, uncemented cup, no problem at all. Another patient, metal on metal, it was painful, removed with minimum bone loss, and there was minimum bone loss, only small areas of contained defect, and a highly porous cup, primary cemented, uncemented acetabulum shell was used, and she did very well. So type 1 are quite simple. Going on to type 2, bone loss, or type 2 of bone deficiency, Paprosky type 2. There are 3 types, A, B, and C, with 3 cardinal features. The superior migration of the existing components is less than 3 centimeters. You have at least 50% of host bone for osseointegration. And the most important point is anterior and posterior columns are intact and they're supportive to a hemispherical uncemented shell. There is no significant osteolysis, either an ischium or teardrop on X-rays. Type 2A is a contained supromedial defect. This is one example, 18 years back.
We have to see one like this daily.
Hello. So this was THA done 18 years back. This was, the acetabulum was loose. This is after removal, contained defect, supromedial defect, grafted primary cup used, no issues. Another example, type 2A, again, supromedial deficiency of bone grafted in a primary cup used. There is good stability, and then again, there is no issue. Type 2B, there'll be supralateral migration or supralateral bone loss, uncontained defect, superior rim loss less than 1/3, and more than 2/3 rim is intact, and the remaining columns can support a uncemented hemispherical cup. Once an example, I performed stage 2 in this case. This was infected ASR, stage 1 already done, came to me for stage 2, small supralateral defect. We could do a primary cup. There was no problem. Another case for revision, acetabular bone loss, mainly supralateral type 2B, and here a jumbo cup was used. You have listened to previous 2 speakers on jumbo cup. Type 2C is mainly a confined medial wall defect with intact rim, which will support the acetabular shell. There is migration of the acetabular component medial to the cohomoloid line. Again, an example, case for revision, acetabular lysis is there, type 2C, and again, a jumbo cup was used. Now, the principle of using a jumbo cup is to convert an oblong cavity with bone deficiency into a hemispherical large cavity without compromising the columns much, and then placing a large acetabular uncemented shell. This is the definition of jumbo cup size by a Mayo Clinic, and these jumbo cups are considered workhorse of revision total hip arthroplasty. It's a good article in JBJS 2018. Now, what does it offer? It offers you, there is no need for bone grafting. It permits weight bearing over a large area of pelvis, but at the same time, it does not restore acetabular bone stock. And it has its own inherent problem. There can be iliopsoas impingement and pain, slightly higher chances of dislocation when you use jumbo cups. When can you not use it? If the rim and floor is highly unsupportive, you cannot use a jumbo cup. One can obviate the needs of cases, sometime by using a jumbo cup. How have been the results? Survival rate about 91% at 16 years. Another study, JBJS, 20 years follow-up. Survivorship was 88%. So it's very, very useful modality using a jumbo cup in the face of bone loss in acetabulum in few cases. What is the preferred combination when you're using jumbo cup? It's better to use enhanced porous coatings, highly cross-linked polyliner, and a large femoral head to reduce the chance of dislocation. Another option in this situation is a cemented cup with impaction bone grafting. This is the only modality which will restore acetabular bone stock, especially in the young patients with excellent long-term results. And another beautiful point is that this modality can be used for all grades of acetabular bone loss. One can use supplemental wedges, meshes, plates to stabilize the situation if it is unstable acetabulum. It has shown good survival rates. The only thing is, it is highly technically demanding procedure and one needs to be properly trained to perform it. Let's go on to type 3 bone deficiency, Papagowski type 3. In type 3, there is more than 1/3 rim which is lost. The bone surface is hardly 50% or less to provide stability, and the remaining rim is highly inadequate to support a cementless hemispherical shell alone to obtain reliable biological fixation. Let's talk about type 3A, less severe of the severe variety. In type 3A, there is superior and lateral migration of the components and superior and lateral bone deficiency. The rim defect involves more than 1/3, but less than half of the circumference. And on X-rays, you will find migration of components more than 3 centimeter, ischial lysis. However, you will find ilioischial and iliopubic lines are largely intact. Just another example. This is a case for revision, supralateral migration, a contained defect in the supralateral side. We used an augment along with highly porous cup. This is the post-op X-ray, and the patient did well in follow-up. This is one-year X-ray follow-up. This patient came to me for re-revision. Revision was already done elsewhere. This patient had loose cup with supralateral deficiency, and again, we use an augment, and this patient did well in follow-up. In these situations, we tend to use highly porous surfaces on acetabular side. This is, again, done elsewhere 2 years back for fracture dislocation hip. This doesn't fit classically in type 3A. It could be between 3 and 3B. The lateral view, CT scan workup done. They were mainly posterior, superior, and lateral deficiency. And here we could get away with using a shim and highly porous acetabular shell. This is post-op X-ray at 2 months, and this is X-ray at 6 months. This patient also did well. So in these difficult situations, one can use highly porous augments, wedges, shims, buttresses. Now, these highly porous acetabular components, they have revolutionized the acetabular revisions because they can still work even if there is 40% of less viable, stable, bony bed available. Because of their higher coefficient of friction, they give you good initial stability. Because of higher porosity, there is better osteoconductivity. There is less stress shielding because of good modulus of elasticity. And the best part is you can drill holes through these cups in good bone stock area. These are the various varieties available: Gription from J&J, Tantalum, and Regenerex. And they have shown good results even at 17.5-year follow-up, almost 80%, more than 80% survival. More severe grade, bone loss, 3B, where there is a high chance of occult pelvic discontinuity. In 3B, the rim defect is higher, more than half of the circumference. Usually less than 40% of host bone is available. There is no inherent stability if you use hemispherical implant alone. And on X-ray, there is more than 3 centimeters of superior migration, extensive ischial osteolysis, and complete destruction of the teardrop. One needs to remember these 4 key elements which signify occult pelvic discontinuity: visible transverse fracture line, medial shift of hemipelvis, rotation of hemipelvis, and obturator foramen asymmetry. If it is there in 3B, there is high suspicion of pelvic discontinuity. There are high chances of pelvic discontinuity with more than 3 centimeter superior migration of implants. This was infected bipolar with grade 3B loss. However, on CT scan, there was no pelvic discontinuity. The columns were thin but still available 2 stage done after stage 1. This is temporary spacers. While putting the implant, these were the columns and floor. They were thinned out, but still available. We could get away with using a jumbo cup, and patient still doing well. It's just 2 years now. One can use in this situation, again, metal augments with cup. Type T3C, again, a metal augment and a large jumbo cup was used. And there is a good article by Neil in GBJS on handling chronic pelvic discontinuity with the use of distraction technique with a jumbo cup and modular porous metal acetabulum augments. Now, for difficult cases, one can use anti-protusio cages. My previous speakers have dealt with this aspect. This is one of the good modality for pelvic discontinuity where patient cannot afford much. This is low-cost reconstruction. The only thing is cages do not provide a biological outer surface for bone in growth, and one has to restore bone stock using grafts. Another example, type 3B, pelvic discontinuity, basic studies done, and bone grafting along with a cage was used. Another patient with type 3B bone deficiency, and again, similar thing was done, bone grafting and cage was used. Now, anti-protusio cages, they have their own inherent problems, and in about 10 to 20%, there is midterm failure. But again, it simplifies their future revision by reconstituting the bone stock. And as a practical point, if you want to avoid early failure, one should not forget to put these dome screws, which provide additional stability. Sharing with you one example, this was a acetabulum fracture in a 70-year-old female, history of fixation 2 years back, came to us walking with pain, and we did CT scan, etc. Basic studies done. We took it as a stable anterior column, and we thought we'll get away with bone grafting and a primary cup. But we were a bit, I think, overconfident. Within 6 months, everything fell apart. It was not united, and the plate was not providing adequate stability. And then we have to revise this case by using bone graft and a cage and a cemented cup, and the patient is doing well. So messages in case of instability, whenever you suspect, don't hesitate to use cage. Cage alone, but the only problem is cage have early fill in 5 to 10 years. To avoid that, it's better to use a cup cage construct, where you use a cup on the outer surface of cage to make it there is osseointegration on the outer surface. Once you use this combination, both the implants gain. The cage gets an outer surface, which is osseointegrative, and the cup gets initial stability so that there's good osseointegration of bone, and both of them combined give a good stability. And it has been shown that if you use cup cage reconstruction, it is better than using conventional cages alone. In midterm, 7-year survivorship was 87% with cup cage and just half if you use only cage. So it's better to use cup cage. The only problem is affordability. One example, pelvic discontinuity, and a cup, after studies, and then a cup cage combination was used, and the patient did well in follow-up. Just to summarize, for these problematic cases, you have highly porous augments, wedges, buttresses, shims, etc. to handle. Type 3A and type 3B, laparoscopy grade, they can be handled with these modern modular implants. Now, custom tri-phase cup, I don't have any personal experience, but it can be custom made, and it has been shown that it gives good result in long-term follow-up in 20-year experience. There has been good survival of this custom tri-phase cup. Last 3 slides for the sake of completion. Whole acetabular allograft. In difficult scenarios, flying buttress graft not used anymore nowadays because you have metal augments available. Same is figure of 7. We have buttress augments available. One can use that. For the sake of completion, I'm mentioning this, and we have already discussed, my previous speakers have discussed about Hive Center. One can, in difficult situations with acetabular bone loss, go ahead with Hive Center. Only thing you don't have to lateralize the cup, keep it medialized, and one can go up to 1 to 2 centimeters superior. There's no problem. Thank you very much.
Thank you so much, sir, for sharing your vast experience in management of acetabular bone defects and total hip arthroplasty. Laparoscopy classification, as you very rightly said, plays a very important role in managing these situations. And jumbo cups, the role of jumbo cups in these difficult scenarios, as you very rightly highlighted, the role of impaction bone grafting with cemented cup, as well as the entry protrusio cages, the tantalum cup cages, and not to forget the custom tri-flange cup, as you mentioned. Thank you so much, sir, for sharing your experience. We now move on to our last presentation. Dr. Sanjay Srivastava, sir, would be joining us from Lucknow, and he would be speaking to us on cementing techniques in total hip arthroplasty. Over to you, sir.
Good evening, friends. After listening to all these wonderful presentations from the experts in the field of hip arthroplasty, coming back to the basics, and I still believe that good cementing technique with a cemented total hip implant is the bread and butter of every orthopedic surgeon as far as India is concerned. It's a simple technique, but if you really have to learn it by heart, and the cost is cut down and you are still able to provide our patient a good functioning joint for a very long time. A good cementing is like a meditation. Most of us do it like running, but it should be done like meditation. You relax, take a deep breath, and do it calmly. That's very, very important if you really want to produce good result with the cementing. And the cementing technique is actually a combination of all those three things. A good cementing technique, a wonderful bed preparation, and your surgical techniques. All these three combined will lead to a good outcome as far as cementing of the total hip replacement is concerned. For a successful cementing, first and the foremost thing which need is a good spongy cancellous bone, and in which we can introduce bone cement and create a good bone cement interlock. And that is very important for the long-term survivorship of the cement. So when we are doing a cementing, this thing should be remaining in our mind, that what we are going to achieve with that. And usually the failure is, if you have done a good cementing, the failure would be because the biological response of the bone, not because of the primary cementing itself. And it's also important to understand that you need at least 2 to 3 millimeter of cement all around your implant for a proper loading of the bone with the cement without fracture of the cement mantle. So this is important whether you are doing it on the acetabular side or you are doing it on the femur side. Coming to the bone bed preparation, as on the acetabular side, you do reaming, try to expose this spongy bone of the acetabulum, and then you try to put few anchorage holes in the acetabulum, and the purpose is to provide a primary anchorage as well as to increase the surface area on which our cement will be acting. On the femoral side, it is important to do broaching, not reaming. You have to do broaching so that this cancellous bone along the cortical surfaces is maintained, and that is important for fixation of the cement and your implant. And distal femoral plug is very, very important to convert this open cavity into closed cavity so that you can pressurize that well, and ultimately you are able to produce good bone cement introduction. Along with these, the brushing of the surface to remove the dirt, to remove the clots and the bone spicules is important, a good lavage of the surface, and to keep the surface dry as far as possible. Again, the purpose is the same. The minimum tissue between the cement and the spongy bone, and the good penetration of the so ultimately you want to preserve the cancellous bone and to create a good micro interlock. So this is the basis of your cementing, what you are going to achieve. And let's try to understand in today's scenario what we call it the third generation cementing technique, what we are using. So most of the time we are using an intramedullary cup. As I told you earlier, that the purpose is to create a closed cavity, and once you have put in a plug, you try to clean the bone bed, put a pack to keep it dry. You have to insert the cement in a retrograde fraction from tip to the top. And if your facility is available and you are able to afford it, you can use these vacuum mixing techniques to reduce the porosity of the cement. Otherwise, most of us are using the hand mixing. But it has to be a slow churning of the cement. Do not try to do it fast so that more air bubble are trapped. So you have to do it in such a way that the least amount of air should be trapped, and that is good for the strength of the cement. And once you have introduced the cement, the pressurization of the cement mantle is very, very important, whether you are working on the femoral side or you are working on the acetabular side. And again, once you are inserting your femoral implant, it is imperative to use a distal centralizer, and if possible, proximal centralizer also. But proximal you can visualize and keep the stem in center under your vision, and distal centralizer has to be used so that your process is well aligned and a proper placement of the processes can be done. To start with the femoral side, you do sequential rasping with the broaches provided by the company which implant you are using. And the ideal side of the broach would be once your proximal metaphysis is completely filling with the broach, and to your gentle rotational movement, it should be stable. So that is the correct size of the broach to which you should reach. And again, I would like to emphasize that do not reach in the femoral canal. Try to broach it, right? Reaming will remove all these cancellous bone, and you will be landing up with a smooth cortical surface, which is not going to survive long. And once you have done the broaching, and after trial you have checked that hip is stable, and you are happy with the position, make sure that you mark the depth of the insertion of your trial implant as well as the version of the implant with the cautery. And the purpose is that the length of the hip will be same once you are inserting the implant, and you will not be missing the version of the implant, because that does happen with the cemented hips. You have done trial in one version, and once you are inserting your implant, that version changes. So it's very important to maintain that. And many of the time, by choice, we want to change that version or change that dip, and that you can do once you are inserting your final implant. So this is how once you have done a clean broaching, and you insert a distal femoral plug to the level approximately 10 millimeter beyond the tip of the implant, so that there is a cement plug below the tip of the implant supporting it, preventing the subsidence of the implant. So this is very important, and this will be judged by the final implant you are using. You must know what is the length of the implant and how deep your plug should go. Then you go for the pulse lavage, and the purpose is to remove all the bone clots and bony spicules, and you want to create a clean bone bed for the further insertion of the cement. And you can use a dry sponge, or you can use an adrenaline soaked sponge if your anesthetist allows, or you can use a hydrogen peroxide. I always use hydrogen peroxide. Many of the people, they don't prefer to use it. And once you have removed that sponge, you can see the clean, dry surface available for the cement insertion. And the next thing would be to put in an infant feeding tube inside the canal. And the purpose is anything which is down there still remaining can be removed, as well as when you are inserting the cement in a retrograde fashion, the airlock can be prevented, and cement, a complete column of the cement can be made. And it is very, very important that you start injecting cement from here and come up to create a single column of cement, and always use a cement gun. Once you have inserted your cement, then the next thing would be to pressurize that cement, and you need a proximal femoral sleeve or proximal femoral seal to block the femur, and then you pressurize. And it is important, as you insert the cement and hold it for a while, give the cement to percolate, give time of cement to percolate between the spicules, and you can see this area. As you inject more, the fat is coming out, or the weeping of the trochanter, what is called, and that indicates that cement is being percolated inside the spongy bone, and fat is being replaced. And then next thing would be to pressurize the proximal area of the cement with a thumb, so that the trochanteric area also get more pressurization and cement is better penetrated, and put some more cement before going for the final implantation. A word of caution when you are injecting the cement or putting cement in it, because we all have read and we all have seen that it can cause cardiac complications and arrhythmias. We must inform our anesthetist before inserting the cement. Cement should be inserted in a mid time. That is, it should not be too liquid, it should not be too flowy, or it should not be too firm. So that the monomer in the cement is reduced and chances of embolization of monomer is less and the chances of embolization is less. Secondly, when we are dealing with the osteoporotic bones, or even though we have to be more cautious, and an over-pressurization of the femur should be avoided in these cases. So that's very, very important when you are injecting a cement. And once you have pressurized the cement, then it's time to insert your stem, and it is important to insert stem in the correct axis in the center of the proximal femur, and you should only insert it up to this less than what is your final level of insertion. And then once cement is getting firm, then you push it to the final level so that you don't accidentally go more deep. And once you are inserting your stem finally, you actually pressurize cement more and you create a better cement mantle. And it is very, very important, as I said before, to mark these areas of level of insertion as well as your version of insertion, so that everything is done in a proper way and to proper level. Another important thing is, whenever we are inserting this stem, we have to be slow and gradual in a constant speed. It should not be done in a very hurried manner, because as you go inside, if you put stem in very fast way, you actually do not give time for cement to pressurize, and you will not be able to create that good cement mantle around. And you might again go much deeper. Coming to the acetabular side, as with the acetabular surgery, whether you are doing cementing or uncementing, you have to have a good circumferential view of the acetabulum, and then you do decortication of the bone and you try to expose the subchondral spongy bone. And on that note, first you have to do the medial reaming so that you bottom the acetabulum, and then you do the peripheral reaming. And once a total acetabular subchondral bone is exposed, you can do multiple drill hole with a 10 millimeter drill, as many as you can, and you should enter into the ileum for approximately 8 to 10 millimeter depth. The purpose is to give a multiple anchorage hold for a primary stability of the cup, as well as to increase the surface area on which your cement will be acting. And then you do a pulse lavage, and your whole bone should be visible clearly like this, so that you have a good bone bed on which your cement can percolate down. Next thing is pressurization, right? Pressurization is also equally important on the acetabular side, and you have to use a proper special pressurizer which seals the periphery and create pressure inside. You put the cement, you try to put a pressurizer, whatever is the appropriate size pressurizer, hold the pressure for at least a minute so that the cement is getting time to percolate inside the spongy bone. That's very important. Second thing is, do not put too much of pressure so that your acetabular pressurizer is reaching to the bottom. That is wrong. So you can pressurize 1 or 2 times, and then you can use thumb pressure to put more cement, and finger pressurization can be done. Once pressurization has been done, you can put in a final cup. Choosing a final cup is most important, that you choose a cup which has a polymethyl methacrylate beads all around, and the purpose is to provide an equal spacing of cement all around, so you don't have to worry about that. So it's important to use a cup, something which has these beads around. And when putting this cup, it is important to put cup first in more close fashion or horizontal fashion, push it towards the base of the acetabulum, and then correct it and bring it to your final position. right? And once you are happy about the final position, just put on a head pusher and maintain it. Do not push it too much, just maintain the pressure so that cup don't come out. Finally, once you have completed your surgery or in the post-operative X-ray, this is the kind of look you should be having. Adequate 3 to 5 millimeter of cement mantle around the cup. A sunburst appearance, your cement is entering into the holes you have created, and there is a good integration of the cement to the bone. On the femur side, you should be able to see the whiteout appearance. So that indicates that you have been sufficiently pressurized and cement is adequately there to provide a good stability for long-term survival. Hence, the take-home message would be to preserve the cancellous bone, use the pulsatile lavage. When you are putting the cement, it should be of medium viscosity and put in a retrograde fashion. Sustained pressurization for at least a minute should be provided on both the sides for sufficient penetration of the bone or the bone cement. Added with the thumb pressurization both on the proximal femur as well as the acetabular side. Once you insert the cup, first it is a more horizontal or more open cup, closed cup, and then you bring it to the natural position. There should be insertion of the stem in a slow fashion and always hold the implant once you have reached to the final position in a non-engaging instrument, whether with a thumb or with something which is not directly connected to the cup or the stem. The purpose is your hand movement should not be transferred there while cement is setting. If you follow all these techniques and these things, I think you should be able to provide your every patient a good cement mantle which should be having a lifetime survivorship for the patient. Thank you very much for your patient sharing.
Thank you, Sanjay sir, for sharing valuable tips and tricks for cementing in total hip arthroplasty. I really appreciate cementing is just like meditation, and one has to be very calm and performing this step. I would like to apply this in every surgery and would like to be slow as much as possible and get my steps rightly done. With this, we come to the end of the session on hip arthroplasty. I would request our panelists, Dr. Jamal Ashraf sir and Dr. Rajeev Anand sir, to kindly chair the session of question and answers.
I think, Anurag, we need to skip this session because we are already late by 1 hour and 10 minutes.
Sure, sir. So quickly moving on to our next session, I would like to call our moderator, Dr. Mrinal Sharma from Faridabad, to start our session on cases on hip and knee. Over to you, sir.
If you have any queries, you can ask in the chat box, and I think our faculty will be more than happy to answer that and request them to answer. Thanks.
Well, I'd like to thank Prayagraj Orthopaedic Association and UPOA to invite me as a moderator for chairing the session on complex cases in hip and knee. And it's been a wonderful session. Both sessions have been great. And I would like to invite the panelist with me available here, Professor R.B. Kalia from Rishikesh. Sir, you are there?
Yeah, I'm there.
Yes. And we have... okay, welcome. And we have Professor Abhay Elhence from Jodhpur. He's from AIIMS Jodhpur. Dr. Abhay, you're there? Dr. Abhay, can you hear me? You're there? So we'll keep it like that we'll ask the case presenters to present the cases, and we'll make them stop in between, and we'll have some question and answers from the panelists, and go about how they are going to handle those situations. So let's have the first presenter here. Dr. Amit Mishra is there from Gorakhpur, and he's going to present on total hip arthroplasty and ankylosed hips. Dr. Amit, you're there?
Yes, sir, I'm there.
Let's share your, you should share your screen. Yes.
Thank you, sir. Thank you, POC and UPOA, for giving me the opportunity to present the case here. Okay. I am presenting this case of Mr. Subhas. He is around 56-year-old male. This is his X-ray. And he is teacher by occupation, Around 32 years back, he had pain in the left hip initially, which is progressive. Subsequently, he had pain in the right hip also. Initially, some conservative management done with traction and medications. Later on, in 1991, he underwent a surgery for his left hip. However, no document is made available by them. Patient was walking with aid till 2001. In 2001, he again was operated for his right hip, following which patient started walking with support, but developed stiffness in back and neck. Subsequently, he became wheelchair bound. So it is a case of ankylosing spondylitis. In ankylosing spondylitis, usually involved in 30 to 50% time, the hip involvement is there. 90% time, it is a bilateral hip involvement. Younger the age of onset, as with my patient, the disease, the higher likelihood of hip involvement, disabling deformities along with the stiffness of the spine. What are our goals? Our goal is to relieve the pain, increase in the range of motion, enhance the mobility, eradication of the flexion contractures, and somehow correction of the posture. Evaluation, pre-op evaluation will be based on the pain and stiffness which patient have, obliquity of the pelvis, if there is any contracture of the hip or knee, and involvement of spine, the discrepancy of limb length, and definitely about the contralateral hip and both the knees. Evaluation pre-op also involve a radiograph of the spine, standing lateral view of the pelvis, rheumatologist consultation, anti-TNF alpha agent should be stopped, pre-op templating, and what to do first. Correct the deformity of the hip or the spine. Usually, we used to correct the deformity of the hip because we are not well versed with the spinal deformities. So, this is the patient with fully ankylosed hip. Typically is traversing. So, in the left hip, there must be a trochanteric osteotomy done because the trochanter is at the lower level as compared to the right. So, how I proceeded? I proceeded in 2018, operated his right hip by the reverse hybrid THR. I had planned for the uncemented THR, but on reaming, I had I had used the posterior approach for this, and in lateral position, when I have the cut over the so-called neck and start reaming from there, because I go on reaming down medially to get some foveal tissue, but I doesn't get any foveal tissue there. So I use the reaming the drill bit to assess the depth of the stabulum, and luckily I got before 5 mm I used to got it stopped, and in between I also taken the some Siam views there, and this is the X-ray of post-op X-ray which I got after the first hip done. This is the range of motion. Abduction is there, some flexion is there with some restrictions, and this is when the patient came for me for after 9 months for the second hip. This is the adduction which I got in the right hip, and after 9 months I had again operated him with the same plan, and I went to do the same procedure there, but because there is some distortion, and I use the same cup size and went to the similar reaming pattern, but somehow I break some medial wall, which result in some splittage of the cement in the pelvis. And this is the post-op X-ray of the left hip. The recent follow-up I get of him. This is the recent follow-up. The patient is able to stand comfortably. this is the abduction, because in the left hip there is some restriction of abduction, maybe due to the trochanteric osteotomy. I have to do some trochanteric advancement there, but I had not done. Thank you for the presentation.
Dr. Amit, congratulations on doing a difficult case.
Thank you, sir.
However, if I would be doing the case, I would look at least one very important thing preoperatively, and that would be a CT scan.
Okay, sir.
So that I should know how posterior the trochanter is. In a fused hip, if the trochanter is very posterior, it makes a lot of sense to go laterally than posteriorly, because then it becomes easier for you to identify the inferior part of the acetabulum and probably put a cup with much ease, because you will not find any landmark in a completely fused hip. One. The second observation I have is that you need to factor in the spinopelvic parameters very, very carefully, especially in an ankylosing spondylitis patient. It is not an easy thing to do. You really need to work on it. You need to get lateral x-rays, spine, understand what is the condition of the sacrum, its inclination, the pelvic incidence, and the pelvic tilt. Because it's not just enough to antivert and incline the cup. You have to find out what is the angle of anti-inclination. And even in your post-operative phase, you need to study the angle of anti-inclination that you targeted and what you achieved. The second thing I would like to say is that when you are reaming for a fused hip, you have to first very carefully identify the inferior part of the acetabulum. And if you do not do that, the bone is soft. In an ankylosed hip, the bone is very soft. So you start with a very small reamer inferiorly, aligning it to the inferior edge of the acetabulum. Acetabulum inferior edge, you will always be able to identify. So you start very carefully and you use imaging. There is no way you can just put a cup in the perfect position because there are no landmarks available to you. So my suggestion would be that you use imaging, right? So it is always better to start with a very small reamer, place it inferiorly, start reaming from inferior, gradually go inside, take your time, image it, and then probably a porous coated cup would give you the best possible result. Even there, you put a trial and you see how deep you are, what is the inclination you're getting, what is the anti-version you're getting. And it is far easier for you to restore anti-inclination if you go laterally than posteriorly, especially in a fused hip, because most of them would be fused in external rotation. So the trochanter will always create you trouble to get your anti-version right. So these are my thoughts about this. And if you're going to do one side, it makes a lot of sense to do the next side very quickly. You can't wait for 9 months, because in 9 months, you are creating a situation in which there are higher chances of dislocation, because you have a fused spine, you have a fused hip on the opposite side, and now you have done one which is mobile, and the patient has started walking on it. So you are creating a situation in which you have a higher chance of dislocation. So these are my thoughts about your case.
Thank you, sir.
Thank you, Dr. Kalia, for sharing your opinion about the fused hips. I have few comments to make. Dr. Abhay is not here. Then few things you need to understand is that fused hips can be in either in flexion and adduction, or they can be in external rotation and abduction. So you need to customize your approach accordingly. If it's in adduction and external rotation, you try to go anteriorly. If it's in flexion and internal rotation, you try and go posteriorly. The other thing is usually these patients have a extended hip and the fused spine. So the anti-version of the acetabulum needs to be reduced, because a lot of times commonly they dislocate anteriorly. So that's one concept that you need to keep in mind. The other thing is when both the hips are fused, it is always better to either do them on the same day or within few days, not waiting for a long time, which Dr. Kalia has also told you. What you have done is you have probably over-reamed the acetabulum, and that's why you need to use a cemented cup. So ideally, you should use the CM, which everyone would tell you after you've done an in situ osteotomy and the femur has been moved away. You need to ream. You need to know the exact acetabulum where you need to place that. So if you template beforehand using the Ranawa triangle method, you will be able to know where actually you need to ream and put your acetabular cup. Even if you've gone little, because the bone is soft, you will always find, the fat pad sign always will be there. So you need to stop there. That is very important in these patients to be taken care of. And sometimes you might need to use the dual approach, the bone-slash dual approach, where if you started posteriorly, but you're not able to dislocate or cut, you can go with a mini anterior, extend the approach anteriorly through the femur, and then you can have the dual approach can be used in these patients, and always keep tripolar cups handy in these situations, because sometimes the soft tissue sleeve is not that good because of the bony adhesions, and the patient not being walking for a long time. You need those kinds of things to be taken care. So these are the basic things. If any of the other faculty members has anything else to add on to this case, I think the right side was better than the left side.
Than the left side, yes, yes.
You should have learned from the right side and done an uncemented cup on the left side.
But the duration, sir, mainly is not depend upon us only. It depend upon the patient also. He reverted back only after 9 months.
Yes. We take your point, but we should try and convince them to get both sides done.
I think Mr. Mrinal, we need to move to the next case.
Yes,
I'd like to comment on that.
Sanjay, sir, please.
Yeah, I'd like to add few comments. Firstly, there's no harm in doing a cemented hip in these cases because the bone is very soft, and we have been doing it for ages. We have done ankylosing spondylitis fused hip. Even in my follow-up, we have more than 20 years follow-up. So they do well. The only thing is, I'll come back to my presentation again, because the cementing which you did on the other side is not very good. Apart from what we have discussed, from where to stop and where to start, where to stop, how to place cup, that's fine. That is common to everything. But if you see your X-ray, which is you have taken 9 months later, even that is showing a reducing line between the cement and the bone. So that cup is not going to survive for very long. If you see the amount of cement you have put, it is not sufficient to provide support. It is very good you have attempted a very difficult case, but that is no excuse for doing it well. Because these implants, they should last long. Usually these ankylosing patients, they are low demand patients. Even if you put a simple primary THR cup, a regular quality cup, it is going to last because it doesn't strain. But the cementing has to be very good if you are going for cemented. Uncemented again has a problem because bone is so soft, you hammer anything, you don't get press fit. So that becomes another problem. And as Mrinal has pointed out, the fat pad is your savior. You start from the transverse ligament, the inferior part of the acetabulum, take the smallest possible reamer, keep reaming slowly. As soon as you get the fat pad, you know you have reached the place. And in between, always check with the C-arm. You are going into dark. You don't have any landmark or parameter available. So you have to use all your methods and methodologies to check that. And as you said, on the right side, you use the drill bit to assess the depth. So there's no harm. You take a drill bit, make a hole, judge the depth of the bone available to you with a depth gauge, so you know where you are going. So all these things can prevent what happened on the other side. So we have to learn from these cases what not to do in the next time, right?
Thank you, sir. Thank you very much.
Thanks for your comments, Dr. Sanjay. Much appreciated. We'll go to the next case by Dr. Unmesh Chakravarti from Varanasi. Dr. Unmesh, please present your case. He's going to present on totally complex case of a knee. Complex knee.
Yeah, it's knee.
Yes.
Yeah, it's knee. Okay. Thank you so much. I would like to thank UPOA and Prayagraj Orthopaedic Association for inviting me. Am I audible?
Yes.
Okay.
Yeah, very much.
So the conference has been great, and I think the last presentation by Dr. Amit was very good, very challenging case, and the point of the panelists was very great and very good. That a complex does not mean that we do a shoddy job and need to learn. And again, the point emphasized by Sanjay said that cementing is very important. So again, it's a knee case, but again, keeping these points in mind, I would just like to present what what I did. So that's a 70-year-old lady, old case of almost burnt out rheumatoid, COPD and hypertension. So she had already got her right knee replaced almost 4 or 5 years back. And now she was having a lot of pain in the left knee. So having had a right knee stent implant done, I thought that it's a good time to advise her for the left knee, and she should have got it before. But then again, as you know, there are patient variables. And again, after the advice, she disappeared. And 4 to 5 days down the line, she came with attendants, and they said that she's just unable to walk, unable to bear weight on the left leg, and with severe pain. So we got the X-rays, and that's what had happened. So, any comments here?
Yeah, it's a stress fracture, and it has happened because the bone was inherently very weak. And did she have any history of minor trauma, or she just had this?
She just
toppled. Pardon?
She just toppled while walking.
Yeah, she must have had a minor fall because the fibula, if it is broken,
Fibula is also.
yeah, so that means that she must have had a very minor fall, and it suggests that the bone is extremely soft, because this kind of fracture with just a tumble or just a lurch, if it is happening, what it really means is that you have a problem with your total knee as well, because you will have things like sinkage of your tibial tray, you will have problem. Does she have any neuropathy? Because there appears to be a lot of destruction in her knee. So my concern would be...
Actually, so if we revert back to the previous X-ray, you see that there's only a medial defect. Probably she has also fractured her lateral condyle now. So there's a fracture of the tibia fibula, and she has a fracture of the lateral condyle now. So it's basically a metaphyseal fracture as well as sharp fracture.
Yeah, so you have a complex situation. You will have to go for probably a long stem and a sleeve probably as well, and with some allograft also handy, because the bone cut that you're going to take may not give you enough bone to graft that lateral defect, which looks like a contained defect. I'm not very sure. I would get a CT scan to characterize this defect. And definitely a CT scan, and probably be ready with a long uncemented stem with augments as well.
Yeah.
So,
what did you do?
So, interestingly, I got some more history, and there was more to it. There's a bipolar process on top of the knee, which has a broken stem.
Has a broken stem. Yes.
Yes, you can see the distal stem is broken. And she's been working on this bipolar processes for almost like 10 years now. And that K-wire marker is a 25 centimeter marker on the tibia and the femur.
So I think the area of concern here is the hip, the knee. We would probably not touch the hip at the moment because the patient has had acute injury. I think you should tell us what you have done. What was your plan?
So what Kalia sir suggested, we got the CTs done, and that's the CT. So there are the posterior condyles are fractured. So combined with the tibia and the fibula, the posterior medial and the posterior lateral condyles, the tibia are also fractured. And here you can clearly see that there's a lateral depression, lateral split, posterior lateral and posterior medial compression fracture.
Kalia, any comments on how would you go about in this case? You've told already you will use a stem, long stem. You will try to build up the proximal tibia. Anything else?
I will still be very much concerned about the femur, because it's a kinetic chain. You can't just get away by doing a knee replacement, and with a prosthesis which is probably only distally fixed. That is why it broke. And a broken prosthesis means that your trouble is not over. And I would still be very, very concerned about the femur as well. Even if it is not symptomatic, it's going to become symptomatic in time to come. So,
Sanjay, anything you'd like to add?
Yeah, and the other thing I would like to say is with the stem inside, ideally you should be doing it under computer navigation, because without navigation it will be extremely difficult to get the femoral cut right. because you won't be able to insert your intramedullary guide beyond a certain limit and you're going to hit the stem. You can do that, but you still will have a problem with getting your femoral component in the correct position. So for this complex situation, I think it would be wiser to use, and with the femur on top, it would be wiser to, if you have computer navigation, this is definitely one that you would navigate. And you on the tibial side, probably you might have to keep a kind of a mesh kind of a thing also to get your defect into a contained kind of place, along with probably a clavicular metal cone in the center, and that would be probably my choice with a proximal cementing and distally uncemented kind of fixation, so that the stem has to be long and it has to be well fitting. And I would also like to keep a small plate handy in case, just to get some rotational stability, because uncemented tibial stems are not really meant to fix tibial fractures. And this is a very unstable kind of a situation with a lot of osteoporosis also. So probably a small plate percutaneously would also be handy for me. And you need probably some amount of allograft also for this. So it's a very complex reconstruction. You have to be very careful with your cuts. You have to be careful with your femoral component. And otherwise, these are the thoughts that I have. These are the things I would prepare for in this patient.
Hey, Dr.
Mrinal,
Mrinal,
you made up your point. Dr. Abhay, hi, where were you? We've been missing you.
I just missed something. Can I make some comments? Couple of things.
Sure.
So if you showed me only the knees, my first instinct will be to evaluate for an inflammatory arthropathy, right? And I would basically plan to do these at the same setting.
She's a case of rheumatoid.
Yeah.
She's a known case of rheumatoid.
Yeah. So if I saw
bad chest, ILD. Yeah.
So that makes it worse. So if I saw this and I don't do bilaterals beyond 70. So in my book, this gets done staged. But if this was less than 70, then I would plan to do this bilaterally. If not, I would not really start mobilizing the contralateral side before I can go in and do the second side. That's a bit of a question mark, but yes, we can talk on that later. But if I evaluated the patient in its entirety, then if you go back to your X-ray on the hip, there are two things which are very important and which stand out to me. So on the picture on the right, if you see, there is remodeling of the bone on the medial side on the stem where it has broken. So that means this stem is loose. As the other thing is that there is no calcar. So this lady has a loose stem, which is not working well. And if I saw this patient in entirety and had to plan it with the hip and bilateral knees in mind, probably I would do the hip and one knee in one sitting, not mobilize this patient extensively, or and do the contralateral knee in the other sitting. The other thing which stands out is that being rheumatoid, this knee is also tending towards valgus. Agreed that she has defects on both the sides, but if you look at the tibia, the way there's fractured and the fibula, hindsight says she could have had an inherent valgus on the left side.
No, she actually had she sustained a fracture. Actually, the right knee was done a few years back by somebody else. And when she came to me with this X-ray, after a few days, she fell and she has a lateral condyle fracture now. So it's a valgus.
So Dr. Abhay, we'll be addressing the loose stem on the hip and this left knee, because the right has already been operated. You probably joined late. So the things to be concerned here are the lateral defect, which is due to the fracture now, an old medial defect due to the severe varus, and a fracture. What probably my opinion would be, we would go in for a total hip with a long stem. At the same time, use a mini plate to stabilize, to give rotational stability at the fracture site, because sometimes the stem would not provide that with the fibula also broken. The other thing is you need to build up the defects. The lateral one, I think it is a contained defect, depressed kind of a fracture of the lateral condyle, where you can just do an impaction grafting and cement. Or if it comes out to, you must keep a sleeve handy with you. That's very important. If there's a big defect, and the medial defect also can be taken care of with the sleeve along with the lateral defect, or otherwise you'll have to build up both the defects with bone grafts. You can use the slivers from the bone, distal femoral bone cuts. and they'll do well. If you're able to balance, you can just put in a primary PFC implant, or if you find instability there, you might need to use a TC3 with the femoral stem also. And the hip can be addressed in the second stage. Obviously, she's come to you with this problem.
So the other thought process on the knee per se is that if you actually look at this knee, classically it doesn't really have only a juxta-articular problem. It is a juxta plus a difficial problem. So in effect, the defect is both a combination of type 1-2 and a type 3 defect, which is both metadifficial. So in that case, it does make a case for wanting to use a cone sleeve along with the stem, which will give both a metaphyseal fixation as well as a difficial fixation. So most cases, I would be able to get away with that and would not probably need to use a unicortical plate, because experience with rheumatoids with unicortical plates has been they don't hold.
What did you do?
I think so there's a vast bag of experience. So unfortunately, I don't have an access to navigation. So
you can use an eye navigate as well.
Point well taken. The femur will be different. Yeah.
No
so okay.
Dr. Sanjay, you have something to say.
Few things here. Firstly, patient is asymptomatic on the hip side. It's very difficult to convince them to go for a hip and then we'll come back to knee. You have to explain that this will give you trouble in the future and that needs to be tackled. That is the first thing. Secondly, bone quality is bad and this is not a pure stress fracture. It is a traumatic fracture in osteoporotic bone. They behave very differently. So you have to have a very good fixation on the tibial side. So my take would be to use a revision system, put on a femoral stem of the femoral reamer of the largest possible size, whatever you can impale on the femur side up to the stem. Then take your femur cut. You'll be able to take the proper femur cut. Then use at least sleeve on the femoral side to provide larger area of fixation without a stem, so that there's an intervening bone between this femoral stem as well as your femoral processes. So you don't have a stress either in that and you can manage with that. Coming to the tibial side seems to be a contained kind of defect on the lateral side. But the trouble is both the condyles are gone. There's a fracture also. So I don't think any kind of bony reconstruction is going to work for a very long time. So you have to use a sleeve on that side. You have to use a stem and you always supplement this stem with a plate. Because it's a trauma. This is not a stable kind of situation. So I think my take would be that. Right away.
We should go to what you did.
Yeah, Mish, let's see what you've done.
Yeah,
so,
please go ahead.
So, so on the tibial side, we use a sleeve because almost after taking there was no way out. It's a long stem. We cemented the sleeve, but unfortunately, some of the cement passed through the fracture site, as you can see. The tray that we used was a mobile bearing tray, so just to reduce the stresses. On the femoral side, again, the cost was an issue. So instead of a sleeve, we used a cemented stem. And again, we can see that there's a very small distance between the tip of the bipolar and the femoral stem. And so this is what happened.
I think Umesh, you've done a good job.
Those are the 1 year, 1, 2, and 3 year follow-up.
I just have one comment to make. You've done an excellent job, Unmesh, and this is probably what everyone would do. And if you don't get a rotational stability, just as Dr. Sanjay and me agree, put in a small plate. We do agree to that. The other thing is, if you're using a cemented stem, use a short stubby stem rather than using a longer stem, because then the short cemented stem does not transfer any stress onto the place where you have your hip implant, and you're going to revise. You might need a longer stem to be placed. This longer stem is going to cause some problems when you're revising the hip. So you don't have options for putting in a longer diaphyseal fitting stems. So it's better to use a short, stubby, cemented stem. That's all I would like to add. Anything else? Or
I like to say one thing.
Yeah, Dr. Kalia, please.
With your femur and your tibia, the femoral stem being so long, you have created a lot of stress riser between the two stems. So if at any moment of time she has another tumble, she will create a periprosthetic fracture because there's a huge stress rise. So a very short cemented stem would probably be my choice. And sometimes you can get away by just putting a sleeve without a stem. So it is not necessary that you need to put a stem and a sleeve all the time. So my choice would have definitely been, in this case, a metaphyseal stem, metaphyseal sleeve on the femoral side, but I would have liked to put a trabecular metal sleeve on the tibial side, because look at this, ultimately, whatever you have done has to have some chance for the bone to regenerate. Ultimately, it's the bone which is the most precious thing. So if you can increase the bone quality, that is going to decrease the number of complications you're going to have 5 years and 10 years down the line. And
so last year,
one more comment. I was not very happy about your flexion gap. Your flexion gap looks to be very large.
Yeah.
And probably you could have gone one size more on the femur and put a posterior augment if required. Because your flexion gap appears to be very large. And since your flexion gap, because this is the primary, and having such a huge spacer would mean that you had a large flexion gap and you tried to build it up by putting a larger poly. So it is better to go for a larger side femur rather than a large poly. And this is a primary case you're doing. And take a very small cut. You need to take in a rheumatoid, you don't need to take an 8 or 9 millimeter cut on the femoral side. You take the smaller cut, you can always go back and do it again. So
actually, in this case, what happened when we're taking the tibial cut, the primary distal tibial cut, there was no bone. It was all flakes of bones, all fractured and fragmented. So just to remove it and so then she fell down. So now the interesting is that so a year down after the last 3-year follow-up, her attendants called me up and they said that she was in Chhattisgarh and she had fallen down and she had the inevitable, she had the fracture. So there she was plated. I don't have those x-rays, but this is the follow-up. And then she just off late came to me with a follow-up and they had done a plating with a bone grafting. So this is the current status.
Had this patient come to you, would you have revised the hip or just plated?
Definitely, I would have revised the hip. Definitely, I would have revised the hip. And another important thing I would have done, I would not have plated like this. I would have put on a long plate, right? A short plate is surprisingly it united. Has it united or there is still a problem with unit? Because
I think the bone grafts they have put anteriorly and posteriorly seems to
agreed,
have done
but
something.
I can in the lateral view I can still see the fracture line. So
there's a fracture line.
Whenever you have a complex situation, you have to plate the whole of the femur now. Right? You can't get away with it. Whatever you do, you have to plate the whole femur. You have to plate from the trochanter to the condyle. Because otherwise, now you again have a problem. That
so
this
now,
might not be right.
So that means first you do the THR and then do a long plate. Because you put a long plate, then you cannot follow it with a THR. So how do you do that?
Absolutely.
With a broken femur, you do the THR and then put a long plate.
So you have to think about doing both the things at the same sitting probably. That will be the best way forward. But now the problem is that since you have put in a long femoral stem, your revision TKR is going to be a big problem because it's not going to have any fixation. So that there is a lot of thought.
We are running a little short of time. We need to go to the next case. Unmesh, a very beautifully presented case. And the take-home message would be obviously in such situations, bypass the defect, bypass the fracture site, keep a constraint implant ready. And obviously you might need to use a sleeve. So these are the 3 things, take-home message for our audience here. And I think who is the next presenter? Dr. Vineet Yadav from Varanasi, is he here?
I think they have removed the distal broken fragment of the prosthesis also while plating.
They must have gone to the fracture site. They must have gone to the fracture.
Taken it out.
But this plating is not adequate. This is not adequate.
That should go
absolutely
from distal femur to the
trochanter. Correct.
Yes.
So, and there are a lot of plates which are available which allow you to do that, and probably they're not available in India, but you have to go the longest possible that you can.
There are AO plates available which have locking screws and options for periprosthetic fractures.
And cables and strut drafts probably are also required.
Regarding periprosthetic plates, I think Synthes have got good plate with the anterior posterior attachment plate, smaller
plates.
So I think that suffices the need for this fixation.
Dr. Vineet, please present your case. Please.
So good evening, everybody.
Good evening. We can hear you. Please share your screen.
Can you see?
Yes, we can see.
So, good evening, everybody. After so much exhaustive session on Sunday evening, I won't take much of time. So, this was a case, a 60-year-old male with no other comorbidities and was treated somewhere 1 year back with debridement and antibiotic loaded cement beads. I don't know. I don't have X-rays of the patient at that time. And he was treated somewhere outside, and he was walking over that with pain. So there was no active signs of infection when he came to us from last 6 months. And at time of presentation, his markers were all normal. So we got this X-ray. So any comments regarding this? So this patient was under government scheme. So you all must be aware of that. And we had to do in some minimal things. So the soft tissue balancing is what matters in these cases, I would like to add. And always the bigger implants are not necessary in these cases, especially in difficult knees. So Dr. Mrinal, Dr. Kalia, sir, do you want to comment?
This is a case with a pre-existing infection. So you want to, with obviously arthritic changes, and you need to go and do a joint replacement. Let's hear it from Dr. Abhay. Dr. Abhay, can you hear me? How will you go ahead with this case? We can't hear you. Host, can you unmute him? Yes.
Yeah, can you tell me the age of this patient? And
this is the 60-year-old male.
And you have no other X-rays?
No other X-rays. This is what he presented.
He has beads inside, so obviously there is a lot of infection, and maybe 1 or 2 surgical attempts have been done, and it must be fibrotic and stiff.
Yeah, so the first thing is to make sure that you have infection control. So the first thought would be basically to go and debride, make sure that there is no infection, send cultures 6 places, and hope everything is fine. The second thing is that there is obviously both metaphyseal bone loss on the tibia as well as possibly bone loss on the femur side, and it's probably going to be very, very stiff. So in the approach, it might need a quadriceps nip so as to be able to expose it better. And the cut on the tibia side probably would almost reaching the fibular head, which means that not very sure if we'll be able to do a primary knee for this patient. So I would have a hinge or a constraint knee ready for this particular patient on the table. Might actually decide to do a primary hinge as well.
Dr. Vinit, did you aspirate the knee before going in?
Yeah, aspirated, it was all dry, and there was no active sign of infection. And he told that from last 6 months, the surgery was uneventful and his knee was okay. He was walking over that with pain, with lurch, and there was limited movement in that.
What you did not grow anything on the culture?
No.
Okay, so it was a dry tap. Did you try and put in saline and then you aspirate the wash and then send it for a culture with at least 15 days of antibiotic-free period?
No, it was just a dry tap.
Okay. Kalia, anything you want to comment?
Yeah, I would like to investigate the patient before I plan anything. I would go and do a knee to him straight away. And the most important thing for me would be to at least get a PET CT scan, probably, and an MRI with contrast. Can't proceed in this case without these 2 things. And I'm still not very clear why this infection. Was it a septic arthritis or what really happened to him?
It was a case of septic arthritis, likely.
Yeah. So in a case of septic arthritis, it is probably not a very wise choice to think about a knee replacement in a 60-year-old gentleman with a perfectly normal opposite knee. And I would be very, very skeptical about trying to do a knee replacement in infection, because that is probably the only contraindications. See, if you already have a knee replaced and you're revising it because of infection, you're already stuck. Here, your options like fusion are also there. So why not choose a fusion rather than a knee replacement in a 60-year-old gentleman who has got probably low, limited mobility, and you can obviate the chance of a flare-up of an infection by a knee replacement completely, and you do it in one stage. You take frozen sections and you just put in an external fixator and fuse the knee. Why knee replacement in every single patient who has a problem in the knee? And that would be my
What if,
first choice.
Dr. Kalia, what if the patient asks you that he needs mobility and he needs pain-free motion?
No.
And
See, he may ask anything, but is it wise to go ahead in a patient who don't even have the bacteria?
There are two schools of thought. One school of thought says that probably if there has been a recurrence infection or the patient doesn't want to get a knee replacement, you should go ahead with fusion. The other school of thought is there you need to rule out infection. You can either do a single stage conversion to a total knee replacement for prior history of prior knee sepsis. The other thing is if on opening up the knee you find some kind of infection or intraoperative frozen sections show more than 5 neutrophils in more than 5 high power fields different sections show infection, then you need to go in for a 2-stage. But I think not offering a total knee replacement would not be the answer here. I would definitely go in for a total knee replacement, ruling out all kinds of infection. With the history, with the going by the PGI international criteria, if the patient is fitting into something where he doesn't have any signs of infection, I will go in for a total knee definitely. If I am doubtful and during surgery I still find some kind of a granulation tissue and my frozen section shows some kind of high power neutrophils more than 5 in 5 sections, I would probably do a 2-stage. But still, I would offer this patient a total knee replacement.
Definitely, sir. Because it's always tough to counsel the patient for knee arthrodesis. And when he goes to some other colleague of yours and he advises that I can give you a good mobile knee, so it will be a tough decision making for both.
Things we need to take care in these patients are these are stiff knees, prior infection, all the tissue is fibrotic. The infection can recur again. It can come back even after a knee replacement. You need to make the patient understand that and he needs to be counseled. You will have to address the bone defect seen here on the medial side and the lateral tibial condyle also. And also, obviously, as Dr. Abhay said, that you need to use quadriceps snip. So these are few things you need to be taken care of and always keep a constrained implant ready in such situations.
The other thing that one has to be careful about in this knee particularly is that you stand a chance of whenever you do get to a situation to do a knee for this patient, you might actually be in a situation where you can lose the extensor mechanism because you might have just a very thin flake of bone over which the ligamentum patella is attached. So lots of issues depending upon what is the pain capacity and what is the affording statement of the patient, I would actually choose my implant. First thing would be to get rid of infection, make sure that I'm good there. Second thing would be to give them a mobile, painless, stable knee. And then I would choose the implant and choose the reconstruction based on what they can afford and what the situation on the table is. But definitely he has a metaphyseal bone loss, which if the patient is affording and can do everything, might get reconstructed with a sleeve or a cone with a trabecular metal cone, which will give them some stability in their metaphysis with the stem. If not, then hinge is a very good option in my armamentarium for this patient.
So that's what we thought of. We were ready with the constrained knees. But seeing this X-ray, I had a doubt there was a huge defect in distal femoral condyle also.
So I'm sorry to interrupt you, Vineet, but I would not plan my procedure on this X-ray. So we are overdoing planning if we are talking what to do on just this X-ray. So that's my first take-home message.
Yes, but there are so many constraints while doing these surgeries, especially in government schemes. So
that's fine, but the message that has to go, we are standing on a platform and a forum. The message that has to go home is that we can't be doing knees without optimal planning and without optimal preparation. So we are actually over discussing based on just this X-ray.
Okay.
Did you get anything else, or what did you do? Let's go ahead with what you've done.
So after counseling and everything, getting CRP done, knee aspiration. And when we were ready for, the patient was ready for replacement, we went ahead. So we opened the knee with a standard medial parapatellar approach. There was huge distal femoral condylar defect. It was on lateral aspect and over also medial side also. We did standard 8 mm cut of the proximal tibia and it was fairly enough tibial plateau left. So, and for these distal femoral defect, we reconstructed it with the graft which we got from proximal tibia and we did put that graft over the defect and then fixed it with screws. So, and the ligament balancing was very nice.
Amit, you're not audible.
Can you hear me?
Yeah, you have to come close to the mic.
Volume is little low.
Okay. Yeah. Is it okay?
Yes, now we can hear you.
So we did fix the graft with screw and on the distal femoral condyle on lateral and medial aspect both, and we did this. So tibial stem was used because the bone was a bit osteoporotic. Femoral condyle defect was managed with bone graft and screw fixation and a standard distal femur. Any comments?
Done a good job, except for one thing.
It was 3 to 4 mm graft.
So for a 3 or 4 millimeter bony defect, you don't really need a graft. You just need cement and screw technique.
So my first comment would be that obviously it's a great reconstruction, looks very nice, and hope your patient did very well. But my first comment would be that the actual situation probably was not as the preoperative X-ray showed like. And because this is a fairly straightforward standard kind of a reconstruction that we were able to do for the knee. So this picture actually paints an absolutely different situation. So we would need scanograms, we would need the investigation profile, we would need a CT if at all to see, actually what is the defect like. Because the primary message that has to go in from any such forum would be that you can only execute what you have adequately planned for. So randomness on the table is not a message that we would like to give.
You've taken a very thick tibial cut because we can't see any defects on the tibia in this case. Whereas on the X-rays, we have defects on the medial side and the lateral condyle as well.
So there you can see there's some medial defect on tibia, but there was no lateral defect in that. So this was all standard. I think 8 mm. I did it around 3 years back. And I think 8 mm distal proximal tibia cut was taken, and then we added 2 mm more.
Doesn't seem like that the 8 mm tibial cut is going to address those defects on the X-rays.
Yes.
Abhay, would you like to comment?
Yeah, that's exactly what I'm saying. So your reconstruction does not seem to suggest that this is the same preoperative X-ray. So obviously we don't have adequate information.
I think the cut is also coming to the level of the fibula. It was not
Yeah, it is
something more than 8 mm.
cut. It's a very deep tubular cut.
Yeah.
Yeah.
Then obviously you've obviated the need for reconstruction of defects by cutting more. And the other thing I would like to comment is probably what you've used is a bone graft. With the patient with previous infection, history of infection, try not to use bone grafts. Use metal wedges. That is very important because if the infection occurs, that graft is going to go into non-union and it will be a source of further infection in such cases.
Okay.
So
one more comment, Vinit, I'd like to make is your femur appears to be undersized.
Okay.
The posterior condylar offset is not proper. So because of that, you will have a problem with balancing because you will have a large flexion gap also. Did you have a large flexion gap after reconstruction?
It was pretty good. The soft tissue balancing was quite good on.
But was your flexion gap large?
It was not that large. It looked nice.
Must be large, but I think you should keep TC3 ready in these patients. I'm telling you, because you will not be able, with the posterior femoral offset being 0 in this case, you will definitely have a large flexion gap. This patient you will be putting a larger insert, and then patient will be having fixed flexion deformity of almost 20 to 30 degrees. And then the patient will still have problems post-operatively. So with the TC3, you will be able to manage that discrepancy. So you can do anything with the primary knee, but to get the best results, it's better to use the required design of the implant, which actually serves the purpose and gives you the best function. So it's very important.
May I ask where these screws in the femur are exactly?
So these 2 screws are in on the medial and on the lateral condyle, and one is on the medial condyle.
Okay, I think good job, but
so this is a 3-year-old X-ray, 3-year follow-up.
So you have loosening.
Yeah, might be.
Dr. Abhay, Dr. Kalia, any comments, please?
So the other thing, it's either the X-ray view or something else.
This is view. The X-rays are in bit of rotation.
Yeah. So again, not great to be able to comment, but yes, it's definite loosening on the tibial side. There is some element of new bone formation. I wonder if the patient is infection free. And the other thing is that is your femur in flexion, or is it just again the view which is seeming so? And as Dr. Kalia said, I'm not sure if it is appropriately sized.
Did this patient have recurrent swellings in the knee?
So this is his video, latest picture and latest video what he did send to me. I think it's almost 3 years, right knee.
Doesn't seem like it's infected as such, and he's not in limp. So you'll have to wait and watch. He'll need a revision soon, probably.
Yes,
tibia is getting loose, it's depressed, and this is probably happening due to non-reconstruction of the proximal tibia.
Yes.
The deeper you go in the metaphysis, the bone becomes soft. You understand? Even if you stemmed it, it's going to sink down completely. Either you should have used sleeve, or you should have built up the bone and got the joint line elevation proper at the proper level. So these are basic things. This patient is doing well.
Yes.
God knows still how.
That's true, but there are so many constraints in Indian scenario, especially working on these patients. Yes, I completely agree with you. Yes, what the best you should deliver with what are the best implants in these cases. But yeah, I would say that in so many conditions you are not getting these things on table. So that's the problem. That's the issue. So you have to manage with the basic things you have in hand.
Okay. Any other comments? Anyone else? Or we'll go with the next case.
Cost cannot be a consideration.
Yeah.
In a complex reconstruction or a revision, cost is not a consideration. The battle of an orthopedic surgeon is the longevity of his reconstruction. Anything will work for a few years, but then what? Then think about what next. So if you're going to revise this knee now, then are you going to cut any corners? You can't cut any corners, right? And what I feel is it is better not to put your knife on a patient who cannot afford or whatever. Whichever scheme he is through, fine. But if you can't really do a good reconstruction, it's going to fail in 2-3 years. He is going to be in an even more difficult situation at 2-3 years, because then all the options that you're going to have are going to be even more expensive. So I think the message that should go to the audience is that for a complex reconstruction, affordability has to be thought for. Agreed. You can cut a few corners here and there, but you can't cut all the corners, because ultimately you're going to have an even difficult situation after a few years. So think about that.
I think
the next revision and the next revision.
I can think of only one line: planning to fail is fail. Is failure to plan is planning to fail.
I have one thing to tell. I have actually just going to publish one article, which is a new classification on stiff knees. So it's going to be published in Indian Journal of Orthopedics soon. That's a new classification given by me on stiff knees. You should all read that article that tells you about all the situations in a stiff knee, with prior infection, without infection, with arthrodesis, without arthrodesis. That is going to be a super paper for everyone in the Indian scenario to read. And I think it will be there in 2-3 months in August edition. So I think we'll go to the next case with Dr. Ankit Varshney from Agra is going to present the case.
Dr. Mrinal,
yes, Dr. Noop.
Can I interfere? I'm so sorry.
Yes.
We are running very late. So can we finish up both the cases in a short time?
Take 5 minutes each, sir.
Yeah. Thank you.
Okay. Ankit is presenting. Dr. Ankit from Agra. So tell us a brief history about your case and rush to the X-rays. We'll just do more of discussion rather than your presentation. We just want to know what is the case and what you have done, and then we can have a good discussion on that topic.
Sure. Just a second. Okay, I cannot do it. So is my screen visible?
Yes, yes.
Yeah, so this was the case of a 45-year-old female who presented with a failure of neck femur screws, and then I advised her total hip replacement. She went to other surgeon where hemi-arthroplasty was planned, and surgery was abandoned as per the patient due to some intraoperative complication. She presented to me after 5 months of this surgery with some
Ankit,
swelling
can you go
around.
full screen? Ankit, sorry to interrupt. Can you go full screen?
Sir, I'm trying, but okay, fine.
Yeah.
Sorry. Yeah. So when she presented to me after this 5 months, there was some swelling around the hip joint. The stitch line was not looking very good. The CRP was 25 and ESR was 40. I thought of doing a hip aspiration, which was negative for infection. Now this is the X-ray, which is open for discussion. What 3 things in my mind was: first, looking at the X-ray, the greater trochanter was shattered. What about the abductors and what about the infection? The case is open.
Dr. Ankit, how did you aspirate the hip?
I aspirated from the intersecting point, like I draw a line from the anterior superior iliac spine down and a line from the greater trochanteric tip to upward. The intersecting point goes from there. I insert the needle towards the hip joint under C-arm guidance.
Was it dry? Was it a dry
tap? It was a dry tap. I don't inject fluid inside it and then aspirate because there may be chances that I may inject the infection in it.
You ruled out infection. You thought there is no infection, or you?
No, I thought there was infection because the CRP markers were CRP was 25. Not very conclusive.
Resorption of the femoral head, which is pointing towards infection.
No, sir. There's no resorption. As I told, the patient was posted for hemiarthroplasty. The surgeon had taken out the hip, the femoral head, and then when he was trying to insert the implant, probably this is my story because the patient just told me that there was some intraoperative complication and the surgery was abandoned.
Do we see a fracture on the femoral shaft also?
That is the fracture, sir.
Yes.
What happened
Dr.
inside?
Abhay, Dr. Kalia, what are your comments on the X-rays?
Yeah, probably I would aspirate to the medial side. So sometimes, by trying this approach from the putting a needle from the medial side, you would be able to get, definitely there is some fluid inside it.
So I went inside the acetabulum. My needle was hitting the floor of the acetabulum under CM.
Agreed, but the pouch is medial, so it's better to go through the medial, put your needle medial, and you have to do it again and again. There is only one answer.
Point taken. Next.
One. Then second thing is trying to plan anything on this X-ray is not going to be enough. You basically need an MRI with contrast. Because MRI with contrast will show you much more what you really are dealing with. Because infection is the biggest concern with your raised ESR and CRP. And a dry tap or a culture which is negative does not rule out infection. So you would probably definitely need a contrast MRI before you can say anything. It will show all the areas of inflammation and it will give you a pretty good idea. If you have a facility of a technician scan, this is again a patient who definitely requires a technician scan.
Okay, Dr. Kalia, we are short of time. We just need pointers. That's it.
Okay, fine. So if the infection after multiple aspirations is not there and you want to do a reconstruction, then probably a distally fixing stem, a conical stem would be my choice. And I would be also be prepared to do an osteotomy of the femur at the fracture site, because if you don't have a straight line, it's not going to happen, right? So you will have to be ready with an osteotomy of the femur also.
So will you be preferring a standard implant, or will you be keeping a constraint with you because the abductor is already gone and GT is shattered?
Yeah, for the abductors, probably a dual mobility cup would be my choice. I really can't reconstruct the abductors with this shattering kind of a thing there. So I would be ready with a dual mobility cup probably, or a very large femoral, as large a head that I can put inside. And probably there might be some defects on the acetabular side, so you definitely need to work it out with the CT scan preoperative. So a lot of preoperative planning needs to go into this. You need to find out what is the line of... Pardon?
Kalia, please. Dr. Ankit, do you have CT scan or MRI to share with us?
No, sir.
You didn't do any of those?
No, sir.
Okay, so you should have got the MRI, a contrast MRI, and probably a CT scan to see the defect, and the MRI would give you an idea about if there is any collection in the joint or there is a full-fledged infection there.
Right,
so what did you do? Let's go ahead. What did you do?
So I went in with all the implant and two-stage revision also planning was there.
9 बज रहा है अभी भी discussion चल रहा है.
Two-stage revision was planned. So I went in for revision, but there was some suspicious tissue inside. So the tip of the GT, I could also see what the GT condition was there. The abductors were deficient. There was no frank mobility at the fracture site. So what I planned was inside a 1.5 revision, which is a technique done by endoclinic Hamburg. So I modified this technique and I used the smallest bipolar and covered it with complete antibiotic cement. And then when the cement was set, I just hammered this implant inside the femoral canal and reduced it. The culture now came out to be positive, which was the Staphylococcus and sensitive to vancoil linezolid. Okay. This is the XA post first 1.5 division, modified 1.5 division. After this, 1 week of IV vancomycin followed by 3 weeks of oral linezolid, 3 consecutive tests, ESR less than 20 and CRP less than 10 with 2 weeks interval was negative. Then I posted this case for the final revision. Intraoperative, I sent again the cultures and I just waited for the report for a frozen section type of a thing, which my microbiologist friend did it right near the operative room. Now, what was the plan? So I planned for the standard cup with a long distal loading stem because the fracture had already united. But when I reduced it, I found that it was not very stable. So I just converted it into a dual mobility cup. So this is a dual mobility cup with a long distal loading stem. 6 weeks follow-up. This case is already 1.5 years old. Patient couldn't able to send the new access. So sorry for that. But the patient is comfortable and doing fine. Any comments on the access?
Ankit, you've done all 3 things right. You have done the two-stage surgery. You have used your longer stem to bypass the defect, and you've used your dual mobility for the abductor loss. So you've done everything which should be perfect, and your hip is also doing well. And hopefully it will do well if the infection does not come back. Any comments from Dr. Kalia, Dr. Abhay, or anyone else from the panel?
My preference would have been a conical kind of a Wagner stem. Solution stem is great. We have all used
this a solution?
I am shifting to conical stem, so I am a strong user for these.
No, I agree. See, the problem with the stem is this is a brittle stem. And
yes, sir.
Fixed. So don't think that it's a honky-dory situation. You know, whenever you revise something or do difficult, be ready for the next cake that's going to come your way. So
I think you've done a very good job.
That this stem can break. Because you have hardly any possibility.
We have a lot of problems with this stem, but I have almost 26, 27 cases who are doing well with this. I think it's a good stem, when it was introduced.
In the short term, yes.
But
in the long term, 5 years and 10 years, it has got
Ankit, it's an absolutely perfectly done case. Congratulations. Let's go to Swaroop Patel for the next case. Swaroop, you're presenting, Dr. Swaroop. Dr. Swaroop, who is presenting the last case? Dr. Swaroop or Dr. Ravi? Dr. Ravi is here? I can't see him.
Last case was Ravi's case, I think.
Okay, so Ravi is not there. Dr. Ravi, is he there? I can't see him. Dr. Swaroop is there.
You are. Yes.
So should we ask Dr. Swaroop to present if Dr. Ravi is not here?
Yes, I can, sir. I can. You have to allow me screen sharing.
Yeah, please. Okay, Dr. Swaroop.
Sir, you are allowed to share the screen.
Please share your screen. Yes.
Yes, sir. Just give me a second. I hope the screen is visible.
Yes, please go ahead, Swaroop.
Yeah, 1 second, sir. So this is a
Dr. Abhay is here or he's left?
Here, I'm here.
Yeah, so just show us your face because we can't make out whether you are here. So I will invite you. Yeah.
This is a
okay. Please go ahead with your case.
Fracture of tibia in post-operative TK. Just right, yes. Just a brief history. She is a 48-year-old female. She is a government. She works in a government office. She had a fall from a rickshaw, and this is her X-ray, which shows the periprosthetic fracture. And this is a all poly system which was done 2 years back. And we do not have any implant details.
Okay, Dr. Abhay, would you like to take that?
Yeah, definitely. would want to rule out infection. Why did it break? And definitely would need a revision.
She had a fall.
Yeah, and not.
She had a fall, sir.
The only comment I would have here is that she has a fairly large flexion extension space. So she's definitely had a. I'm not sure if the fracture was because of the fall or the fall was precipitated because of instability. So that's the first question that I want to ask.
Go both ways.
Yeah, so there's a huge flexion extension space, so it can go both ways. So the fall can be precipitated by instability, and it could be a instability causing a fall. In any case, it would need a revision, and one would need to stabilize the tibia and bypass the metaphyseal defect, as well as on the femur side. I'm not sure if you can use the same implant along with which knee was this?
So we don't have any details about the implant, sir.
Yeah, so would basically need to rule out infection, would be wary of instability, and would definitely need a revision, and would send cultures, would go in with the idea of having to do a full-blown revision. Hello?
What did you do?
So
Dr. Sarup, what did you do?
Yes, sir. So this was the fracture which I could see, just a pointer. So I got a CT done. And what CT started showing it there on these films, there is no loosening of the implant from the bone, and the bone is quite large. And I thought I will be able to fix it. So these are the CT images.
You plan to fix it?
Yes, sir. Because it was stable on CT, and so this is the fracture which we can appreciate. This is the lateral side, this is the medial side. So once I'm moving the fracture, you can see. So the implant is very well stable, and this is the fracture line. So this is the intraoperative C-arm images, the kind of reduction which I got. And these are the bone graft which I used, and then I fixed it with a plate. You can see distal radius right on the medial side. And so after fixing, I checked for the instability, and it was perfectly stable. The fracture site was not mobile after fixation. So this is the immediate post-op, and this is 2 years follow-up, and she's happy and she's doing all her work.
Dr. Abhay, Dr. Kalia.
Great result.
One thing I like to comment is that your posterior slope is too much. If you just go back, your posterior slope appears to be a lot.
He has changed that on the fixation, He has corrected that posterior slope. That is because of the depressed fracture that you're seeing. It's not there in this X-ray.
But agreed, what you've done is commendable. But in the long term, I don't know how this is going to fare. Because once you have a fracture periprosthetic, that interface between the prosthesis, the living and the non-living is terribly compromised, and whatever you do below it probably is not going to give you long-term results. It's lucky that you have a 2-year follow-up which shows a reasonably okay kind of a function, but I will be still be.
I think Dr. Sarup has been very lucky that it is united, because as an arthroplasty surgeon, I would revise it. I would revise it to a long stem with a sleeve probably.
So I have 2 comments to make on this. My first comment is nothing can be, nothing and no principle can question a successful result. Yes, but Dr. Sarup has been lucky to get away with this, but he has essentially treated this with a trauma surgeon's eye and not as an arthroplasty surgeon's eye, because you would think differently if you had something like a periprosthetic fracture happening with a proximal tibia lesion. And well, he's lucky to have gotten away with it, and great result. That's all we can say.
An arthroplastic guy would revise it to a longer stem, and the trauma surgeon would always like to fix it. So, but anyways, the result is good. That should be the take-home message. If you're not able to reconstruct, were you prepared to doing a revision? That is the thing you should be telling our audience.
I was completely prepared to do it, and the CT helped me a lot in deciding whether there is how much bone is there. Will I be able to fix it or not? So the CT was a key here. Before just X-ray was not good enough, and even then I had all the plans. I temporarily fixed it, and then I tried intraoperatively checking how is the stability. And when I was very much satisfied, yes, I can fix it with the bone graft and the plate, then I went ahead and did a fixation.
So, Dr. Swaroop, I would differ with your thought process just a shade. As I said initially, that CTs in this situation is not a great guide to let you know if your implant is stable, because these are situations where you could have had either of two things: instability leading to the path fracture, or a trip and fall causing the fracture. So you do not know which one of the two situations was working in your given case. But so that is one thought process, which is a little bit of a question, that you just see the CT and you say that the prosthesis was stable. The other thing is that there are so many other situations which could have been at play leading to this fracture. So yes, but you have a great result, so that's what matters in the end.
I think the all poly implant helped him in getting the screws, maybe probably through the implant, and obtaining more stability. Had it been a metal base plate, he would not have done it.
Dr. Swaroop can tell it better.
Yes, sir, I completely agree with the panelist, because it is an all poly implant. The interface between the all poly implant, the cement and the bone can very well be visualized. And during intraoperative fixation, I think I may have passed some screws through the all poly stem which was there. So that all poly implant helped me a lot.
Okay, Dr. Swaroop. Anyways, as an arthroplasty surgeon, I would have revised it. Never would have thought of fixing it. Anyways, but still the take-home message is what ends well is good for everyone, Dr. Ravi is here. Should we ask him to present his case within 2-3 minutes?
Sure. We can go ahead.
Yes, Dr. Ravi, please.
Once we are already so late, why leave him?
Yes. He was not showing up on the screen, so now he's there. We'll definitely ask him to present. Dr. Ravi Garg, please. Welcome you. How are you?
Fine, sir. Fine. Thank you, sir, to allow me a case.
Yes. Please. Go ahead.
Swaroop, can you
share your screen? Dr.
Yes,
Swaroop, you should stop sharing.
Yeah, I have done that.
Umesh, can you start my slide?
Recording stopped.
Should I have to present from my side?
Yeah. Because some problem is there.
Mesh, is it
Recording in progress.
Dr. Ravi, you can just tell us.
Yeah.
Here you are. Okay.
Yeah.
Share, sir.
Go to for the fourth slide. Yeah, this is a case of 15 or 16 years old boy having a severe sepsis due to infection in his left hip. He had gone with the severe sepsis, septic shock, and there is a developing ARDS on NIV. So initially being treated as in the severe case of as a severe sepsis on NIV. So there is first X-ray is this is the left hip. It seems normal at the time of presentation of his admission on the hospital. Have a left hip tenderness, swelling, painful movement with severe sepsis. Next slide. The patient gradually developed respiratory distress, and you see the chest X-ray. This is the sign of ARDS is there. Next. Now, after 10 days of admission in ICU, patient recovered from the sepsis and ARDS, shifted to ward, and this is the X-ray of this left hip. Next. Now the patient is treated as the line of septic arthritis left hip, aspiration cytology from left hip done, sent for culture. Culture was sterile because the broad spectrum antibiotic, heavy antibiotic was given to the patient. abdominal traction was given, and patient is discharged with the regular follow-up. After 1 month of follow-up, next. Now, there is an infection in the proximal part of the femoral metaphyseal area, and there is an infection in the hip joint, at the epiphyseal area. After 1 month of picture. Patient on the continuous IV antibiotics and traction on bed rest. Now, after 2 months, gradually patient developed the chronic septic arthritis and chronic osteomyelitis left femoral proximal femur. So the IV antibiotic along with the rifampicin and isoniazid we started, and traction was given. So next, after 9 months, patient was advised on non-weight bearing on the diseased limb, but I allow the patient to start walking with the support of crutches on normal limb. But there is a slipping of capital epiphysis, capital femoral epiphysis, and the infection is still persisting, as I see on the femoral metaphyseal area. So next, this is after 1 year, slipping gradually increasing, but the fine thing is that the infection is on seeing the X-ray, the infection is gradually improving and the proximal metaphyseal area, as I see on the previous X-ray, comparing to the previous X-ray. So the antibiotic continue. I continue the rifampicin, isoniazid for 1.5 to 1.5, at least 2 years. But the slipping is increased. The shortening is present 5 to 6 centimeter. And after 2 years, at the age of patient approximately 18 years of age, the ATT now stopped. The biological markers, CRP, SR and other markers return to the normal limits. Patient on walking on crutches. And after 2.5 years, we plan for the THR. Now, the stop, Umesh. I would like to discuss this X-ray with the faculty.
So what you're presenting here is a tubercular hip.
Yeah, tubercular or subacute infection is septic arthritis or chronic arthritis, chronic osteomyelitis on the proximal hip, and gradually patient improve after 2 years.
Did you get a RT-PCR done or a gram staining for tuberculosis?
Yeah. RT-PCR
culture, did it come out to be positive? Anything which is in favor of tuberculosis that you're saying, and you put the patient on ATP?
I start for the anti-tubercular drug because the rifampicin usually has help as an antibiotic, also the MRSA. So I start the rifampicin for the long-term use. We used the previously oral linezolid for the 3 months. After that, I continue the rifampicin isoniazid for at least 1.5 to 18 months at least.
Did you put the patient on any traction?
Yeah. Initially we put on the patient on traction, but later we allow the patient for walking with the normal limb on crutches. But before we plan the THR, again I put the patient on skeletal traction for 1 month.
But you did not plan to do any debridement initially and go inside and clean the hip or something of that sort, get some cultures from inside, some
aspiration cytology was done at the time of admission when he was in the severe sepsis.
Dr. Kalia, any comments?
Again, the same thing. You cannot rule out an infection because your tap was not there or it was a negative culture, right? You have to make a lot of attempt to try to isolate the bacteria. Now, since it's already 1.5 years old, you won't...
2.5 years. Is 2.5 years.
But still, planning this patient without a contrast MRI probably is not right. And you probably need to get a contrast MRI, very, very important, and a technician scan before you think about doing a total hip. See, the only contraindication to a total hip is infection, right? So if you have infection in the whole femur and you put a hip inside, it's going to flare up. No matter how many antibiotics you give, an X-ray always underreports infection, right? So if it looks like it's clearing on X-ray, it's a good thing, but you can never be sure about it.
So I would be very, very
So,
cautious
sir,
about.
what are you suggesting for the rule out of infection? Non-invasive method.
You can never completely rule out an infection.
Yeah.
A. So what you really need is at least a technetium scan that will pick up any hot spots anywhere in the femur or the acetabulum. And the second thing is a contrast MRI. Again, it will give you a clue whether you are dealing with inflammation at sites that are not visible on X-rays. So these are the two very basic investigations that you need to do, and you don't plan a hip without these investigations. You can never rule out an infection just by a tap. Yeah.
Abhay, you want to add anything? He's not here. So the most important
most
thing
of the things
Kalia has
have
already.
been
Yeah.
discussed.
Okay, please.
Yeah. So this, to my mind, is a pure infection still. We don't know if we are subclinical right now or we are active, or but we definitely have affection of the acetabulum. We definitely have a huge lytic lesion in the femur head. And before I decide to do anything or any metal work inside, it needs to be worked up completely. And you've all discussed what exactly we need to investigate this patient for. So you can't just
now we are dealing with this sequelae septic hip. That is what we are going to. If we rule out infection, there's no infection. Now we are having a sequelae septic hip. How do you go about it? Dr. Ravi, what have you done?
Yeah, what are the next slides, Umesh? So the challenges is the 5 to 6 centimeter of the shortening is there, and there's the dysplastic type of hip as the underdeveloped proximal femoral, and there's shallow acetabulum as filled up healed fibrous tissue, previous infection. The implant choice. What are the implant choice by the panelist?
You show us what you've done, then we'll let you know.
So at a 16-year-old boy, I will definitely consider CHOI reconstruction of the hip rather than a total hip. So that's my first thought. So
okay.
So Dr. Ravi, what have you done?
Yeah. The preoperative high tibial pin is cultured, and I would apply the Umesh, show the X-ray. Yeah, this is panacle with coral stem, uncemented. And this is the smallest side of the coral stem. This is size 6, and it's the metal on, the ceramic on poly. And we achieved the true acetabulum, which is filled with fibrous tissue. I again take the biopsy from this fibrous tissue and send for the culture and histopathology at the postoperatively. And that was the negative for the any infection. And this is the immediate post-op X-ray I've taken.
You have a long-term follow-up, 1 year.
Yeah. Umesh, this is the lateral view, immediate post-op. And is the after 1 month clinical picture of patient. The boys. The important thing is the shortening has fully recovered. No LLD is there. This is the 6-month X-ray.
Yes, we can see it is appreciable on the X-rays also. There would not be any shortening. I think you've done a good job using uncemented implants. We would have done the same. And no infection has not come back, so that's good for the patient. But you need to keep watching these patients.
Yes, I have a 4-year follow-up. That's Umesh, next slide is there. This is the 4-year X-ray. After 4 years, no sign of infection, and patient is recovered fully.
Very great.
Next slide.
Comments from Dr. Abhay, Dr. Kalia, any other panelists, faculty?
Because I thought the 2 and 5 years is the enough for the any infection to heal. Is the antibiotic is given.
You have been lucky.
Ravi,
you have been very lucky. Without infection, you have a 4-year.
Is the walking video of that guy?
That's all very fine. You have a great result, but a great result means that you need to introspect probably a little bit more. And
my question is the panelist: how long we should continue the antibiotic if the technetium scan or this contrast MRI show the infection? So how long we continue the antibiotics? What are the protocols?
After how much period you've given the antibiotics? So if you've given antibiotics for 4 to 6 weeks and the infection is not controlled, you might need to debride that hip. It will not, that infection will not go then. You need to debride, do a girdle stone initially, go ahead with the second stage surgery, put in a spacer, and then go ahead with the final total hip. So do a 2-stage procedure then. But infection needs to be ruled out with proper investigations, proper testing. You need to be 100% sure that there is no residual infection there, because otherwise you will burn your fingers. The other thing is, if the patient, if the proximal femur is showing you osteomyelitic changes like a periosteal reaction, those are the patients who are at very high risk of getting a reinfection, I'm telling you. That is where the infection comes back in such patients. You need to choose those patients very carefully.
Yeah, so totally agree with what Dr. Mrinal is saying. So the only comment I have to make is that one has to look at the second simplest surgery that you will have to do for any given patient. And especially if that patient is a 17 or an 18-year-old, then even more so.
I think
it's not about the simplest first surgery that you can do. You have to look at the simplest second, third, fourth surgery you'll have to do.
Mrinal, I think we needed to wind up. We are already late by 1 hour.
I would like to thank the panelists and the organizers, and it's to you, Dr. Sanjay, Dr. Anoop, Dr. Anurag, for the closing remarks.
Thank you, sir. Thanks everyone, and especially those who are here with us. It's already 1.5 hours late. It's 9:36, and all of you have taken out your precious time from Sunday evening. So it was an excellent evening from both academic as well as social point of view. We had a meeting after a long time of UPOA. I would thank all of you to be here. I will start with our chief guest for tonight, Dr. Atul Srivastava, sir, for accepting our invitation to attend this meeting. And I would like to thank our UPOA President, Dr. Sanjay Dhawan, sir, and Secretary, Dr. Anoop Agrawal, sir, for their guidance and for giving us a chance, obviously, to organize this event, although virtually. And I would like to thank our POA officials, President Dr. Piyush Mishra, sir, and Secretary Dr. Sachin Yadav, sir, for their support, and all of our speakers for enlightening us with their knowledge and experience, for moderators for conducting the scientific session smoothly, and panelists. And best part of our audience, we had about 193 viewers at the peak, and still we have around 100 viewers. So that is a great number, I think. Sunday evening, it's more than 9:30. So I would like to thank our organizing chairman, Dr. Kapil Kulshesh, sir, for his guidance and support, without which this event was not possible. I would like to thank Deputy Synthesis for their sponsorship, and Deputy Synthesis team, especially Umesh, for his technical support and reaching out to the faculty and audience. I hope you all enjoyed this course and gained something from it that is going to help you in your arthroplasty practice. And I'm hoping to meet all of you in person very soon as the COVID ends. Thank you again. Bye-bye. Namaste.
Bye-bye, everyone. Bye-bye. Bye-bye. Thank you, everybody. Bye-bye. Thank you.
Thank you, sir. Everyone. Thank you.
Thank you, everyone. Thank you.
Recording stopped.
So with your permission, sir, we wanted to end this meeting.
Right. So, Umesh?
Bye, sir.
Fine, all done. Anything else?
Yes, sir.
Anybody else? Anything else?
No, sir. I think we would love to hear from Dr. Kapil. Kapil, sir. I think he's still joining. I think it went really well and fantastic show. We had more than 500 registration, 540 registrations. So I think in between the session, we had almost 300 participants.
Sure, great. I think after the lecture session, we had few great cases. So cases made the session very interesting. So all of we enjoyed the different cases. We had good variety also of hip and knee cases both.
Chalo. Thank you, boss.
Hello, bye-bye. Good night.
Bye, sir.
Everyone. Good night, everyone.
Thank you. Thank you, everyone. Thank you, everyone.
Meet you again. Bye-bye.
See you soon, sir.
Bye.